can I have the CV of Dr. Supriya? Hello.
I think they are busy in letting people in.
Hello, Chindrakala. Hello. Yes. So she is.
Yes, ma'am.
Can I have the CV of Dr. Supriya Jaiswal?
Yes, ma'am.
So she is the Secretary of Patna Obs and Gynae Society, Chief Consultant SM Hospital Patna, and she is the specialist at Government Hospital, communicator for Central ISOPAB, and she is also the East Zone Coordinator for Adolescent Health Committee, FOXY, a very active member, and she is also the aspiring candidate for the chairperson for Adolescent Health Committee this time, FOXY. So all the best, Dr. Supriya, and now I hand over the session to you for the further proceeding. Over to Dr. Supriya.
Thank you very much, Dr. Pratibha, for these wonderful words. So a very good evening and warm regards to one and all present here today for the Knowledge Bytes webinar. Medicine is an oscillation between the two sharp ones of the dilemmas, to do or not to do. So, dear friends, we have curated for you topics that address the common management dilemmas we often come across in our practice. Let us invoke blessings of Almighty and light the lamp of knowledge to dispel the darkness of ignorance. So, let us have the lighting of the lamp, please. So, with the virtual lighting of the lamp, and I request the chief guest and all the dignitaries to join hands in the virtual lighting of the lamp. Thank you, everyone. So today we have a stalwart, a true Foxian, as chief guest, none other than Dr. Leela Vyas, Madam. Madam is former senior professor and unit head IVF consultant, member of Research Review Board, SMS Medical College, Jaipur, senior consultant, Cocoon Hospital, Jaipur, and senior consultant, aesthetic and cosmetic gynecology at Vyas Clinic, Jaipur. So, Madam has so many of organizational positions like Chairperson SR in Rajasthan 2021, Vice President Foxy 2018, President Narchi Rajasthan, President Jaipur Obs and Gynae Society, and Secretary Jaipur Obs and Gynae Society in 2005 to 7. With these words, we are very happy to thank you, ma'am, for accepting to be the chief guest of today's program. So with this, just give us words of blessings. Over to you, ma'am.
You have to unmute yourself, madam.
Madam, unmute kar lijiye.
Namaskar, everyone.
Thank you.
At the outset, I convey sincere thanks to Pratibha ji, Supriya, and all organizers, and for this involving this webinar. The topics you have chosen, yes, the mixed bag, always we prefer that. It should be a mixed bag. So we'll have, intelligence shows that everyone will get in this webinar. Means those who have in this interest in cosmetic, they can come and pure cut obstetrics, the GDM preventive things, those who are thinking of that, fetal medicine, which is the part, and then the day-to-day practice, that is the PID, which we have. And definitely the all speakers, those who are very marvelous. Ragini ji, she is the master of this cosmetics. She has done all ICOG classes and all. So Ragini ji, welcome, and everyone will have this bit of your presentation by this. So these are the problems which you have chosen. And definitely I've seen that you are involving so many societies, that is the Punjab, Rajasthan and Haryana, all are there. So all secretary and
Nothing has happened.
I congratulate you that you all are actively coming forward and accepting their invitation. And I think it is a very good, I was talking with the Kanchan ji that अभी जब अपना physical आएगा, then we will realize no, virtual अच्छा था, because anytime you can, and at a time you are sitting here and you can attend so many webinars. Yes, physical का मुकाबला नहीं है. We want to meet each other. We have that. बिल्कुल कहते हैं ना पक चुके हैं. So that this it should start, and AICOG में यही होने वाला है. I think lecture तो कहेंगे बहुत सुन लिया यार. So that's the need of time, because everyone is got stuck in their own work only. So they need a relaxation, and definitely we all meet and start with that. But the virtual way of doing this teaching or to spreading knowledge, I'll say that, because the knowledge byte, you have given this name to this webinar, is very good. And all Richa as a guest of honor, really I'm very happy to see that all our youngsters are coming forward. And Pratibha ji, aapka, Supriya, Krishna, Kanchan ji, sab, that you all organizers, you all are bringing all means our junior colleagues forward. And Priyankur is there. We have seen Priyankur's work in this time in COVID time, that he is very actively coming. Active. All are very active members. This has been proved in this era of COVID, that when we were virtual meetings we were doing, because so many problems in physical also, that you have planned, जैसे अभी बात हुई कि मेरे को एक उसको attend करना, एक उसको attend करना, but you all are coming, and time is always required. We can't say that while doing virtual you have to give your time. Whether physical and this physical, we will feel new in this 2022 में हम वही रहेंगे, and after that also, oh, इतना travel करना पड़ रहा. So all and knowledge, if we are getting knowledge at sitting at home from all our experts in the Foxy, then definitely it is the most beneficial thing. And I convey all are active members of the Foxy, but those who can give their time to the Foxy, means they have planned to give their time to the Foxy. Those who are contesting for their different posts, my all best wishes to you all, Pratibha ji, Supriya, Dr. Manoj, or Kanchan ji, Priyankur, so everyone, and तुम्हारा IAG का. And I welcome Ragini ji, my good friend. She is going to talk about too tight. Sometimes talk about, means reversely, she will go with the reverse way. गाड़ी को बैक गियर में लेके और वापस आपको भी, if it is loose, then what happens? I think Ragini ji will, she always gives a topic. First, so आप सोचिए कि what is it? Means those who are not in the cosmetics, they will think that what she is going to speak on that. But जो too tight की बात कर रहे हैं, शायद उसको reverse gear में लेके, if too loose, then what happens? These are the problems which are the, that's why we have given, because Ragini ji in 17 से work कर रहे हैं, and in 18 first workshop we did, that is the her unspoken problem. So her unspoken problem हम यहाँ से start हो रहे हैं, and very nicely designed program, that if you start with her unspoken problem and then reaching up to the GDM. So GDM is how it is important that means to prevent a further generation from that. So we are the primary preventer to prevent our country to become a means capital to hone jai rahe, capital to the capital of this diabetes. So this is our becomes a responsibility. So complete for womenhood we are working, and definitely this webinar is one of the example that how the gynecologist thinking on the women's health. And all the best for your this successful webinar, and all the best for your success in your future endeavors. Thank you. Thank you very much.
Thank you, madam. Thank you.
Thank you, madam. Thank you for all your pearls of wisdom and the words of encouragement to all of us. Thank you, madam. So moving ahead, I would now request the guest of honor. We have Chairperson MTP Committee, Foxy, Dr. Richa Sharma, who is going, can we have the CV? Who's doing real great work connecting members of all societies, A, B, and C, especially the C, B, and C great societies all over India. Dr. Richa Sharma, she is loaded with number of awards. Foxy Korean Award, Foxy IPAS Award, late Dr. Praveen, so many. You can see it takes time, like Dr. C.S. Dawn Prize, then Wonder Foxian Award. I think she has lots and lots of awards and edited so many books, stepwise access to hysteroscopy, intrauterine adhesions, Asherman syndrome overview and hysteroscopy. Then she's been given so many awards. She is the winner of Best Care Report Prize, NARCHI, third prize in North Zone Yuva Foxy, second prize in Roundtable Conference North Zone Yuva Foxy. So in different years, as she has noted down, Certificate of Excellence, AOGD, Dr. Sumit Mittal's Gold Medal on Population Stabilization, and then AOGD, Dr. Sumit Mittal's Gold Stabilization on Population in 2016 and 17. Both years she bagged the prize, and she is recipient of so many, more than 75 publications in national international journals, chapters, presented 90 papers in state and national conferences, and organized several workshops, CMEs, training programs. She has really done wonders. Actually, she is really doing very good at in Foxy level. So I welcome you, ma'am, and Dr. Richa Sharma, can you please give your address to us?
Thank you so much, Dr. Supriya, for the wonderful introduction. A very good evening, everybody. And first of all, I thank the conveners of today's webinar, Dr. Pratibha Singh, Madam, and Dr. Supriya Jaiswal. It is a wonderfully designed program. And I think the mixed bag webinar series, it is a wonderful initiative. And this will definitely give a lot of knowledge to the participants regarding the topics which are less discussed and less understood. And today I can see we have a very senior faculty with us. Dr. Ragini Agarwal, ma'am, is there. Then Dr. Anju Soni, and we have senior presidents and secretaries of various societies. So thank you so much. And I can see the election campaigning also is in the full swing. So all my best wishes to all the contestants. And my regards to Dr. Leela Vyas, ma'am, also. And I will not take much time. I think we should proceed for our academic session. So thank you so much, Dr. Pratibha and Dr. Supriya, and wish you all the best for your success of this webinar. Thank you so much. Thank you.
Thank you.
Thank you, Dr. Richa. Thank you so much.
Thank you. And so with this, we start our academics, the session 1, where to try to heard the topic. And the speaker is Dr. Ragini Agarwal, ma'am. And may I have the CV of all the chairpersons? Dr. Preetham, can we have the CV of Dr. Preetham first? She is president of Ajmer OBGY Society. So the first chairperson is Dr. Preetham Kothari. She is president Ajmer OBGY Society, senior consultant at Mittal Hospital Ajmer, Director Kothari, IVF Center Ajmer, then endoscopic surgeon and IVF specialist, ex-assistant professor, JLN Medical College Ajmer. I welcome you, ma'am. The next chairperson is Dr. Prakash Jain. So he is consultant in the OBGY Department of R&T Medical College Udaipur, President Udaipur OBGY Society, former Secretary Udaipur OBGY Society. Special interest in vaginal surgeries. He is faculty in AICOG 2020, faculty in Neurogynec, Endogyne, West Zone Yuva Foxy, and he has been hosted society secretary West Zone Yuva Foxy, then member of Oncology Committee of Foxy, national cricket player, umpire in RCA, founder secretary of Gaurav. So with these words, I welcome you, sir. The next, we have Dr. Anjali Narang. She is consultant at Narang Maternity Hospital, Sirsa Secretary, Sirsa branch of OBGY. So with these words, I hand over the platform to the chairpersons, and may I request Dr. Preetam, President Ajmer OBGY Society, to kindly introduce the speaker, Dr. Ragini Agarwal, madam. Can we have the CV of Dr. Ragini Agarwal? Yes.
Hello, good evening, everyone. Thank you very much for inviting me as a chairperson, all organizers. Dr. Ragini Agarwal, she doesn't need much introduction. She is a Vice President Foxy 2. She was Vice President Foxy 2020 and founder Gurgaon Obstetric Gynae Society, founder President Association of the Obstetric and Gynecologists Haryana. She is the founder President-elect Aesthetic and Regenerative Society India. And she is a founder committee chairperson Aesthetics, Health Indian Menopausal Society, and President Indian Academy of Cosmetics. She has President Indian Academy of Cosmetic, Dermatology and Gynecology, founder chairperson IH Haryana chapter, founder president of Isoperb Gurgaon, and founder president of Haryana. Founder President Haryana Association of Gynae Endoscopy and founder president of Haryana. She has fellow clinical gynecology endoscopy UK master course cosmetic gynecology and laparoscopy, and she is a clinical director of BGY and Mass Head Department of Cosmetic Gynecology and Pelvic Reconstructive Surgery, Pratiksha Hospital, W Pratiksha Hospital, Gurgaon. Welcome, ma'am. And
Thank you so much, Dr. Preetam, for your kind introduction. And my thanks to other chairpersons too who are chairing the session. And thank you, Pratibha, for this invitation. And Supriya is...
Sorry, madam, your CV is different actually they have shared. Which you
No
have
problem, no problem. CV to itna bore ho. And so I will share my screen.
Yes.
Okay. हीरा जी नमस्कार. आपने तो पता नहीं क्या क्या कह दिया हमारे लिए. I just make it and slideshow.
बहुत कम बोला है, अभी तो और बोलना चाहिए था, टाइम नहीं है.
नहीं. So मेरी फुल स्क्रीन आ रही है या नहीं?
नहीं, अभी नहीं आ रही मैडम, फुल स्क्रीन कर रही है.
फुल स्क्रीन करिए.
दोबारा से शेयर करती हूँ, कुछ इसका हो गया है ये. अब आ गई फुल स्क्रीन. So previous, yeah. With blessing of God, I want to thank to each of you, and from where I have taken few photographs and everything from the net, because this particular presentation is not possible without taking the diagrams from the net. So this topic, too tight to hurt, is really the opposite what we always talk about, the looseness. Even for too tight to hurt, people are confused. Really, she is having something, or she's feigning, or this is some problem which is curable or not. Today, with the role of many new things has introduced, which really given some insight for the treatment of these problems, which is age old, nothing new about it. So if you see that business must, it is a sad story. A couple, even every one of us have these patients in our OPD, and they one OPD to another OPD, they really wander around, and many times, many years have gone without consummating marriage. So this word is coined in 1862. Imagine, so long back, It's a reflex-like contraction of the circumvaginal musculature, resulting in a non-consummation of marriage. Recurrent or persistent involuntary, spastic, and painful contraction of the outer 1/3 of the vagina, interfering with the sexual intercourse. Causes may be the emotional, psychological, but sometimes physical causes are also there, like oversensitive nerves at the opening of the vagina, what we can say a part of the vulvodynia, focal vulvodynia. Then there's inflammation or injury to vagina, difficult childbirth and fear to go through it again, and side effects of the certain medicines. But what is sad are the many psychological problems and the blocks. They maybe come from the post traumas like sexual abuse. Many a time it is a childhood sexual abuse which really make this woman totally traumatized. And at this time when husband approaches and all the trauma comes in the mind of her. Painful sex in the past, strict upbringing, that is also play a very big role, that sex is bad. Fatigue, fear, reservations, and many a time the gossip from the married relatives or friends. So half the world's female population suffers from some kind of sexual dysfunction. It affects almost 7% of the women. Many of these patients tend to be quite reserved, not to share their health problems. What you have to, DD, maybe some other reason of the vaginal muscle spasm, superficial dyspareunia, real vestibulodynia, deep dyspareunia, or sometimes very tight hymen ring, which is not possible to go beyond that. It's just like a hard ring which you have to cut. So what are the muscles which involved? We all know when we talk about the outer 1/3 of the vagina, here comes the pelvic muscles. A major chunk is the levator ani, and no doubt a bulbocavernosus also play a role. But this is the levator ani, all three part, ischiococcygis, pubococcygeus, puborectalis, and ischiococcygis. So all three this, along with the pubococcygeus and the bulbocavernosus, they play a role. So what happened actually? One, it is actually true for all kind of the pain. One body has a pain, it anticipates it. Fear and anxiety may contribute. Body automatically tightens vaginal muscle. Tightness makes the painful penetration may be impossible. Pain reinforces or intensify the reflex response. Body again react by bracing, then the avoidance of the intimacy, leading to again increase in the pain. This pain causes a central sensitization from the peripheral pain. Many times there is a consistent of the overlapping elements like hypertonic pelvic floor muscles, pain, anxiety, and difficulty in penetration. There is variable like phobia, involuntary pelvic muscle contraction, or anticipation. So what are the type? Either it is spasmodic or non-spasmodic, or we can divide it like primary. She has never had any intercourse. Secondary, maybe in the past she has, but today she has some problem. Global means unable to place anything in the vagina, maybe her own finger or any other thing. And situational, like able to use a tampon, but tolerate even an early pelvic examination, but cannot have an intercourse. So what are the causes of the superficial pain? Lack of sexual arousal. So FSD patient, basically, you have to see whether this patient is real vaginismus patient or she is having some type of sexual dysfunction, maybe with this particular partner. Maybe there's a lack of a sexual arousal, some type of infection. In a senior person, there's atrophic vaginitis, vulvar dermatosis of many kinds. We all know about the LSE, then drugs or radiotherapy. These all type of the superficial pain will cause a vaginismus, which is of the secondary type or a situational type. Then there's a deep pain of the endometriosis and PID, which we are well versed. So everywhere when we talk about anything, we have to go for a medical history detail. Here, what is important is along with your gender history is a psychosocial history and the sexual history. And you have to gain the trust of the patient. Sit down. Nobody should enter in your OPD. There will be lots of confidence and complete calm attitude, non-judgmental attitude, and no interference, no disturbance. Then when you examine the patient, first talk to her, and woman's ability to tolerate genital exploration by herself or another is also very important to understand. Then with the history, what is important is your psychological understanding. And if you don't have a time, you can't understand the psychological nuances, it is better to take help of a counselor. Now, for the genital examination, you have to exclude the organic pathology. Several consultations may be needed before the woman is ready to be examined. But there's a big difference of a patient of the businessman when it comes to you. You came to know that patient is not having any organic pathology. She has no other complaint than this. They are not able to have a intercourse. So you have to stratify the severity of the vaginismus with the degree of the vaginal spasm and the degree of the fear and anxiety. This is a grading 1, 2, 3, 4. And there's an addition from the Mr. Passig, grade 5, where there's a generalized retreat as in a level 4 plus visceral reaction, maybe palpitation, hyperventilation, sweating, severe trembling. I have seen 3 patients in my life who has had a total vasovagal spasm-like thing. The pulse has even gone. And one has kicked me also. So it is very important. First, you have to stand. You have to talk to the patient and always have a little bit distance and try to touch first. And then gradually go for examination. Never preach them. Never force anything. So what is our aim for the treatment is to break the vicious cycle, replacing the pain by pleasure, spasm by relaxation, make the woman feel that she owns her vagina and can share it for sexual activity should she wish. And the most important thing is your patience, your non-judgmental attitude with a welcoming thing, not saying that she's an abnormal or ye to hota hi hai, you have to cooperate. These type of things should not be done. And when this woman to be referred, if there's any history of the sexual trauma or there's a phobic registration to the either sexual therapist, psychotherapist, or psychiatrist. Those who are less anxious, first you can offer a vaginal trainer which she can use by herself. So how we go about exploration of the phobia, then sex education, then control of the muscles. You can take up the help of a pelvic physiotherapies. And again, systemic vaginal desensitization by botulinum toxins or other modalities. As far as the exercise is concerned, patient has to learn what is the muscles, how she has to take the control. But in the real case of the vaginismus of a grade 3, 4, or even 2, these things are really not very effective. So we all know about the benefits of Kegel exercise. A real vaginismus patient has no benefit of the Kegel exercise ever. But a grade 1 or where you are going with the biofeedback mechanism, patient can understand, and if she is ready, she is learn to relax the exact muscles. Otherwise, you have to go back to something certain treatment like vaginal trainers. They are available on the Amazon in a variable rates. I always advise my patient to buy from the Amazon. So what is the Botox? This is the latest thing which we are all doing it. It is a Clostridium botulinum, and we all know that it causes muscle paralysis, duration of 3 to 4, but sometimes it acts to 6 months also. And onset of effect comes around a week. It is a offline treatment means it is not patented or licensed for this particular treatment. And you have to tell this thing to the patient, because we know today everything has to be documented. We used to it many problems where it is allowed, but in this particular thing or other Botox where we are using to make us beautiful, make us young. I think the most of the Botox is going there today. But still, that is also not an indication which is licensed. So this is the way we have to keep on our trolley, and we dissolve it. Keep while refrigerator, reconstitute with 0.9% saline, use 22, gaze 1 inch long needle. Insert the needle straight into the vial, slowly inject, vacuum to demonstrate that the sterility of the vial is intact. Gently mix the toxin. Don't hilau like this, and neither like this. Really side by side rotation in a very fine way. And usually we used 100 unit in these patients. Then you draw the fluid from the corner, and you have to store this syringe in the refrigerator. But it is better if you dilute less and again dilute less, because when you refrigerate, the potency decrease. But you can use it 4 to 6 weeks. So what we do, we usually go with 100, 40, 40, 20, the 3, 4, 5 o'clock position, and it is injected in the vaginal side wall. Urethra and rectum are carefully avoided to prevent the urinary incontinence or fecal incontinence, but it may happen. Always educate the patient. It is a temporary thing, and you can take a consent for this complication and document it. So pubococcygeus muscle group as a part of the pelvic floor muscle often resemble a tightly drawn fist in the most severe vaginismus cases, and it should get the largest dose of the Botox. So this is the muscles which we are going to give, and always give few, say 10 units on the superficially to bulbospongiosum and other muscles also. Usually, one treatment is sufficient. Once the vagina is progressively stressed, the patient can experience pain-free penetration. A second round of injection is rarely necessary. Once the vagina remains relaxed, dilated for 12 months, the affected vaginal muscles are less likely to resume. Once the patient achieves pain-free penetration, the intercourse with the dilator, the neural response that previously triggered the vaginal spasm gradually shuts down. Indication is the severe or refractory cases of the vaginismus, contraindication, hypersensitivity, or like an infection, pregnancy, coagulopathy, or any disease of the neuromuscular. Side effect, I have told you that fecal and urinary incontinence, or sometimes there's an unusual pressure pain in the vagina that is separate from that particular pain of the vaginismus. Result, more rapid effect, most of the success of the first treatment, but occasionally repetition is allowed. So we never say that you are 100% success. Even in practice, I can say it is a 60 to 70%. Many a time there's so much of the psychological block, they need lots and lots of therapy. Without that, they are not going to get benefited. So this particular program which I have brought it is here. Many times they say do under the local anesthesia or sedation, but it is not possible. I also do always under anesthesia, and this botulinum toxin and bupivacaine, progressive dilatation and post-treatment counseling and the support. So what is important is the post-treatment counseling and support. That is too much important. So when we give this injection, we have to be very careful when we are going at 6 o'clock position, because here comes up between 5 to 7. Although this gentleman has said 5 to 7, but from my side, what I can say, between 5 to 7, you have to be little careful. don't go near 6 and along the sides, because here what happened, it's an anal inspector area, and many a time that patient can have anal incontinence. So bupivacaine injection can be injected on the right and left vaginal walls. Progressive dilatation, patient wake up with the large dilated place. In few patients, what I have done, I have made a mold-like structure like we do in our vaginoplasty, in the neovaginoplasty, and put inside the vagina, specifically if patient is not able to buy the dilator. And that's a wonderful thing when we do it, because it immediately dilates vagina quite a lot, because it's a quite a thick thing, and patient, when you remove it, and patient can understand that she's not having any pain, but she herself, when she does with the dilator, it will give her lots of confidence. So success, because there's no study comparing progressive dilatation under anesthesia, but what we experience is a quite high before and after Botox. So biofeedback, physiotherapy, hypnotherapy may have some little role. Hymenectomy, absolutely there's no role in it until it is because of tight hymen ring. Kegel exercise alone has no role at all. Drugs, again, maybe initially it may have some effect, but not at all. It is have any effect until unless patient has some sexual phobia or some psychological blocks. So what can we prevent business? First, the first thing is sexual education of girls before marriage in the schools, and mother should educate the daughter properly, and premarital sexual guidance and the counseling. So what is there? The education, which I always say to everyone, one day camp, free camp and freebies is not going to change the society. We as a doctors focus on for everything. GDM is coming in the next talk. What is the GDM? It can be controlled by the education and the pre-counseling. So everywhere the education and the counseling is the most important thing. So to conclude, vaginismus, vestibulodynia, dyspareunia overlap. Vaginal muscle spasm is not a valid, reliable diagnostic criteria. Clinical syndrome consists of overlapping elements of hypertonic pelvic floor muscle, pain, anxiety, difficulty in penetration. Line of treatment is there: exploration of phobia, sex education, control of muscles, and injection of botulinum toxin. Thank you so much for your patient hearing.
Thank you, madam. Thank you for your wonderful deliberation. Actually, this is a subject very less touched about amongst us. So we really came to know many new things. So wonderful. Everybody was mesmerized by your talk. So I request the chairpersons to kindly give the closing remarks. Madam Preetham, madam.
Yeah, hello. Today's topic, too tight to hurt, was really discussion was needed for gynecologists particularly, because this is a very common problem these days. Every gynecologist is facing off and on. Patients are coming, and especially at the smaller places, we are giving less weightage to such kind of patients, and we are not that sympathetic to these kind of patients, and we just ignore them or advise this and that, but we are not actually considering them very well. So Dr. Ragini has done a great job. She has explained very well the demand of the patients and how to counsel patients. Very well she explained, and all gynecologists are benefited from this, those who are attending this, and they should develop the trick of treating such patients, and simple mode botulism, Botox injection, which is she has narrated very well. Thank you, Dr. Ragini. Done a good job.
Thank you so much, Dr. Preetham, for your kind words.
So
Excellent talk, madam. Excellent.
आलू गोभी मटर का प्रतिभा आलू तो हो गया, अब गोभी मटर मिला दो और
great sense of humor, madam.
Hello, just a minute, Dr. Supriya.
Yeah.
Actually, I'll request the support to kindly upgrade Dr. Nishu Gupta, Dr. Ashish Kale, Dr. Kiran Arora, madam. I'll request the support, please.
Ma'am, I upgraded ma'am.
Achha.
Nishu Gupta, ma'am. Ma'am need to accept.
Okay. Okay. And Dr. Kiran Arora, madam. And Dr. Ashish Kale. Okay.
Yes, ma'am. Yes, ma'am.
Yeah. Okay. Over to Supriya.
Yeah. So I thank, we have come to the end of the first session, and I thank the speaker, Dr. Ragini Agarwal, madam, and the chairpersons, especially Dr.
Yes.
Preetham Kothari,
Yes.
ma'am, for chairing the
Yes.
session so well. So we move on to the second session. We have medical management, PID, medical management for the second session. The speaker from which is none other than Dr. Anju Soni, who is the chairperson HIV/AIDS Committee of FOXI. To chair the session, we have Dr. Sudesh Agarwal, President Bikaner OBGY Society. Can I have the CV? So she is Professor and former head of Department of OBGY, Sardar Patel Medical College, Bikaner, Rajasthan. She is Diploma in Minimal Access Surgery, Kiel University, Germany, Fellow of Indian College of Obstetrician and Gynecology, Fellow of Indian College of FICMCH, awarded many gold medals for academic excellence, President of Bikaner OBGY Society. With these words, I request you, welcome you, madam. So the next chairperson is Dr. Kiran Arora, ma'am. She is the president. She is an obstetrician and gynecologist, a laparoscopic surgeon. She has got 34 years of experience in private practice and director, Sukhmani Hospital, Sector 38, Gurgaon, President Gurgaon OBGY Society. Madam, I welcome you.
Thank you.
The session. And the third chairperson is Dr. Nishu Gupta, Secretary, Yamuna Nagar, OBGY Society. She is past Secretary, IMA Women's Doctor Wing, then a life member, Indian Medical Association, life member, FOXI, SRIFS, appreciation award received for her exemplary services in Pradhan Mantri Surakshit Matritva Yojana, director and consultant, Single Test Tube Baby Center, Bilaspur, has conducted rural camps, adolescent health camps, and many more school programs. Area of interest are recurrent pregnancy loss and difficult conception. So with these words, I welcome all the chairpersons. I hand over the platform to the chairpersons. So may I request Dr. Sudesh Agarwal, madam, to kindly introduce the speaker, Dr. Anju Soni, ma'am. Over to you, ma'am. And can we have the CV of Dr. Anju Soni, ma'am?
Very good afternoon. Am I audible?
Yes, ma'am.
Yes, madam. Yes.
Okay, okay. So it is a wonderful opportunity. Thanks, Dr. Supriya, for the kind words. And all thanks to the organizers for giving me this opportunity to come across all the esteemed gynecologists and the obstetricians on a virtual platform. That has become reality in this era of COVID pandemic. And to take this talk further, after the aloo, it is the mutton. That is very common, a part and parcel of every sabji, especially in winters. But rather, I would say PID is a thing which is perennial. And in OPDs, it is the white discharge. That is so very common. I will not say all are not PID, but everywhere, even if you are traveling by road, you will find it. Shwes pradhar ke rogi mile, nil shukranu mile. I mean, this is something which is absolutely prevalent. And we have got none other than Dr. Anju Soni, a very friendly figure. Our own Dr. Anju, she is going to present a beautiful lecture on the management of PID. That is a very common thing, especially useful for the UGs and PGs. Of course, PGs might be there for the busy gynecologist and for every day-to-day practice. So Dr. Anju Soni, she requires no introduction, but it is an honor for me to introduce her. So just in short, she is the chairperson of HIV/AIDS committee at the present moment. She is the Secretary General elect 2022. Then she is the president of Jaipur Ops Society, president of Jaipur Menopause Society, that was 17 to 18, committee chairperson of public awareness, vice president jobs 13 to 50, and so many positions she has held from time to time. Each and every one of you are aware of her. She is editor of the Poise magazine 17 to 19. Besides, she has got a lot of laurels and honors in the form of the COVID Warrior Award, Longevity Club Award,
Sudesh,
Wonder
thank
Woman,
you for your
and
kind
so
words.
many things. And if I keep on doing, I am stealing time
Thank you,
from your
thank you
talk.
very much.
So
Thank
over
you,
to
thank
you,
you.
Dr. Anju Soni. I welcome you.
Thank you, Dr. Sudesh, for such kind words. It's my honor that you're sharing my vision. We remember the days when we were roaming in conference time.
There is some problem. There is some, the voice is not clear. So
Great
I don't
time,
know.
and I hope. Is my voice clear? Supriya?
Yeah.
Better. Now better.
Yeah, madam.
Now it is
Am
better,
I,
ma'am.
am I audible?
Yes, yes, now. But
My slides are seen.
yes,
Not full screen. Not full screen.
Yeah, I'm going into slideshow.
Hello. Yeah, you have to accept the request.
Am I seen? Are my slides seen now?
yes, but not in
You
slide
have to
mode.
make it full
slideshow.
screen.
It's not still full screen?
No, ma'am.
It's only your introduction on the screen, madam.
Yeah, okay. Just give me a second.
It is not full screen.
Yeah, just give me, because I can see full screen. So I need to see what is the problem.
Hello.
Ma'am, please stop share, ma'am.
Yeah, I think I'll have to stop here once and then.
Yes, ma'am. Yes, ma'am. Ma'am, may I help you, ma'am?
Yeah, please.
Ma'am, yes, ma'am. Full screen, ma'am.
It's perfect now.
Full screen now?
Perfect, ma'am. Yes, ma'am.
Now my slides are also moving?
Yes, ma'am. Yes, ma'am.
Yes, yes.
But I can't see myself. How do I?
But we can see the slides, ma'am, and you also.
Okay, but I don't know why I can't see myself. It's okay. Yeah, okay, let me check maybe. Yeah, so at the offset, I would like to thank all dear friends, Dr. Pratibha, who is convener of this beautiful program. She's a very, very old friend, and a lot of other friends are there in this, whole program. And she's kept this name of this webinar so aptly, because it is very important to have knowledge of practical subjects which are, required day to day. And there's so much of updates happening for these subjects that it is very, very essential for us to understand. And I would like to thank all Dr. Pratibha for inviting me in this webinar, and I'm thankful to, I mean, if it will take a lot of time if I take everybody's name, but I'm thankful to all dear friends who are there in this program as chairpersons, as speakers, and as contestant of the elections. They have best wishes from my side. So best wishes to all of you, and let me, without wasting my time, let me go
discuss this very, very important topic, the pelvic inflammatory disease, and what medical treatment we should give. Now, to make things more easy, I would like to share a few cases of PID, wherein which I'm sure in coming few slides you will be able to understand what we should do in these cases. A woman comes to us. She's 22 years. She's married only for 2 months. Complaints of pain abdomen, dyspareunia only for a month. Pain increased 5 days back. She gives history of heavy menstrual bleed with dysmenorrhea, LMP 2 days back. Her periods otherwise were regular, normal, with very, very mild dysmenorrhea, and of course contraception they are using as during the unsafe period, and there is no past or family history as significant. Now, when she was examined, the cervix was nearly paralyzed. They were bleeding through the os, and her cervix was down with AVF normal size. The movements of the uterus were tender, and left adnexa was palpable and tender. Her UPT was negative. Now, another case, a para one living with PP IUCD inserted 9 months back, complains of pain abdomen which increased vaginal discharge for 2 months, and LMP was 7 days back. She had menstrual complaints for last 3 months, irregular, followed by regular cycles and normal flow, and heavy menstrual bleeding again for 3 months. And otherwise, past menstrual history is a regular cycles with normal flow, and non-significant family history and past history. Now, when she was examined, her cervix was hypertrophied, bled on touch. There was a mucoid discharge, and copper-T thread was seen. Now, her cervix was forward, uterus RVRF, multi-parous size, and there was a decreased mobility of uterus with bilateral tender hornices. So when we talk of these patients, we have to have an approach of 5 Ps, wherein we have to, when we take the history, we have to talk about the partner, the practices, the protection from STIs, and of course, the past history of sexually transmitted infections, and what are her intentions for the pregnancy. So, this slide though looks slightly busy, but we have to, understand this. When we talk of partners, we have to ask her, are you currently having sex with any kind? What is the gender of your partner? These days, we all know that homosexuality is quite common. And then what are the practices? Is she at any kind? Is she got many any risk of sexually transmitted infections, and what kind of sex she had recently, what kind of sexual contact to have or to have you had? Do you have a vaginal sex, meaning penis in vagina, or do you have any other sex like penis in rectum, or anal sex, or oral sex? All these things have to be found out. Then is she taking any kind of protection for STIs, like she's having any kind of partner is having any kind of diseases like any kind of STI or HIV, and do you or your partner is discuss getting yourself tested for these diseases, or are you using condoms, and what are the protection methods you have used, and is there any past history of STIs? Is very, very important to find out, and especially with HIV. And have you ever been diagnosed with STI in past, and have you ever had any partners who had STI? So these are very important history. Additionally, we have to find out HIV and viral hepatitis is another very important disease which leads to higher risk of having STI. So we have to find out about that also. Have she has been injected with any kind of drugs, or is there any sexual health with which that you have questions about? Now, the next question is she intends to be pregnant. Do you the question we need to ask is, do you would like to have any more children, or how important for you to have prevent pregnancy? Are you or your partner using any kind of contraception, or what would you like to talk about the ways to prevent the pregnancy? So these are very important questions when you come to the pelvic inflammatory disease. So Now, what is pelvic inflammatory disease? It's very, very important to understand. It is a spectrum of inflammatory disorders of upper female genital tract, and with any combination, she may have endometritis, she may have salpingitis or a tubular abscess or a pelvic peritonitis. So one thing very clear, it is inflammation of upper female genital tract, which may involve any part of upper genital tract. Now, why are we talking about it? Why it is important to know about pelvic inflammatory disease? Because it has got vague signs and symptoms, and often it is asymptomatic or very mild. And there is no single finding which is both sensitive and specific. Now, when we look into the pure epidemiology, 1 to 2% of sexually active women who are under the age of 30 are at the risk of having sexually FPIDs. And out of that, 85% have spontaneous infections, which is a huge number. Now, why are we worried about PID? Because if we delay the diagnosis and management, there is a huge risk of having chronic pelvic pain, ill health, tubular abscess, adhesions in the pelvis, ectopic pregnancy, and the most dreaded problem, infertility. So what are the most important causative organisms? We all know that Neisseria gonorrhea or Enterocolitis is the most common, but they are tested positive only in 50% of the cases. And it has been found that we find other bacteria also, like Gardenia vaginalis. These are all anaerobic infections, Streptoagilis. So these are very, very important anaerobic infections, which can also give rise to problem. Then there can be entry-gram negative rods, there could be mycoplasma, uriplasma, etc. Now, how do we diagnose this? There is, as I just said, there is no single historical, physical or laboratory findings which is both sensitive and specific for the diagnosis. And of course, combination of tests detects more women with infection, but may miss out infected women. And because the potential of damage to reproductive system is very, very big, so we should have a low diagnosis, and can be subtle, can lead to inflammatory insult. Now, people say that, it has been found that though laparoscopy is a gold standard to diagnose the problem, and it's very, very reliable to diagnose, but it is not feasible practically in all the cases. We all know that. And it's only reserved when there is a difficulty in diagnosis, differential diagnosis, including salpingitis, ectopic or appendicitis. When we do laparoscopy, we can aspirate the fluid or pus for microbiological study from fallopian tube, ovarian pouch, and also laparoscopy gives a very clear view of a non-responding pelvic mass. So as I said, that laparoscopy has a great role, but it is not justifiably when the symptoms are mild and vague, and it should not be used to it. And another problem with laparoscopy is that we cannot detect endometritis and subtle salpingitis, hence PID is a clinical diagnosis. Now, who are the patients who have to be treated? So basically, how do we diagnose the problem? So when a sexually active woman comes to us and we know that she is at the risk of STIs, and she complains of a pelvic pain or a low abdominal pain, and no other cause we can find out. This is one thing. Another is if a woman comes to us with one or more of these findings, wherein there is cervical motion tenderness, uterine tenderness, or adnexal masses, we have to make our antenna rise. Other criteria which make the diagnosis more confirmed, if any of one of these is present, like predominance of leukocytes in vaginal discharge, cervical discharge, or cervical friability. So PID, when do we say that it is not PID? When the cervical discharge appears normal, there are no WBC observed on wet prep, and additional causes of pain should be considered. So what are the criteria which again confirm that it could be PID? An oral temperature more than 101 temperature, abnormal cervical mucopurulent discharge or cervical friability, presence of abundant number of WBCs on saline microscopy. We all know it's a very simple test, but it's very, very helpful. Elevated ESR, elevated C-reactive protein, and of course, the best is if you can detect Neisseria gonorrhea or trachomatis in the swab test. Now, the specific criteria are when we take an endometrial biopsy and it proves endometritis, excellent. And nowadays, with TVS and a 3D sonography and MRI, we can see thickened, fluid-filled tubes with or without free fluid in the pelvic or a TO mass. And Doppler studies again show a tubal hyperemia, laparoscopic findings in selected cases wherever there is difficulty in differential diagnosis. And women with negative laparoscopy endometritis may be the only sign of PID. So what additional testing we should do? We can do NAT for gonorrhea and trachomatis, but I don't think anybody of us are doing in routine practice. Of course, serological testing of HIV is very important, and of course, urine testing for pregnancy, because you need to tailor-made your treatment accordingly. Now, we all know that we have to know the differential diagnosis. These conditions need to be ruled out: appendicitis, disturbed ectopic, torsion of ovarian pedicle, or hemorrhagic or ruptured ovarian cyst, endometritis, diverticulitis, and UTI. Now, coming to therapy, what are the principles? Why are we talking of PID? Because it is very important to treat these women. They are young, they have a whole future in ahead of them. We don't want to develop any permanent damage to their tubes and ovaries and uterine cavities. So we need to energetically control the infection, prevent the late sequelae, and prevent the reinfection, which is very, very important. You have to prevent the reinfection. So how do we go about it? We have to give broad spectrum coverage of the likely pathogen, which we are suspecting. Multiple parenteral and oral micro regimes are available, which are effective in achieving short-term clinical and microbiological cure. However, infection annihilation of endometrium and fallopian tube is very, very important to prevent the long-term complications. I cannot emphasize this again and again, that it is very important to reduce the long-term complication. There is no optimal treatment we all know, for treatment of PID, because reinfection and complete cure is not easy. Now, how do we tailor-make our regime? The drugs which are effective for gonorrhea are negative endocervical screening, does not rule out upper genital tract infection. So we have to again think that, this area has to be covered. Anaerobic bacteria like bacteroids should be covered. And BV is often present among these women, though we do not do any kind of screening for BV. Now, addition of metrozole is very important because it eradicates anaerobes. It should be initiated as soon as presumptive diagnosis is made, and prevention of long-term sequelae depends on the early administration. Now, what are the hospitalization criteria if a patient of PID comes? They should, no surgical emergency should be there. There is a clear-cut indication of tuberous abscess, or there is a pregnancy with PID, or there is severe illness which is associated with high-grade fever, nausea, vomiting, and she is unable to follow or tolerate the outpatient oral regime. And of course, there is no clinical response to oral medications. So there are different regimes available. So we can give ceftriaxone 1 gram every day for 24 hours, every 24 hours, plus add doxycycline 10 gram twice a day, along with protinidol twice a day. Or we can put the patient on ceftazidime 2 gram IV 12 hourly, plus doxycycline orally, and 2 gram IV 6 hourly ceftazidime along with the doxycycline orally. Now, bioavailability of with oral drugs, when we talk of doxycycline and metronidazole is very good. They are equally effective whether you give doxycycline IV or you give metronidazole orally. They are same bioavailability. Only thing is the tolerance. So we can change oral in after initial response and complete the course for 14 days with 100 milligram doxycycline twice a day and 500 milligram of metronidazole twice a day. Now, there are some alternative regimes available when a patient is not able to tolerate the previous treatment. Then we can put the patient on ampicillin sulbactam plus doxycycline or clindamycin plus gentamicin loading dose. Alternative parental regimes, when we talk about that, we all know that second and third generation cephalosporin like cefotaxime or cefotaxime are less effective than cefotetan or cefotetin, and metronidazole should be added with them to give the gram-negative coverage. Again, ampicillin sulbactam plus doxycycline is effective against trichomonas, gonorrhea, and anaerobes in the woman with tubo-ovarian abscess, and short-term clinical cure rates with azithromycin monotherapy combined with metronidazole are also seen. Now, clindamycin and gentamicin, after clinical improvement of 24 to 48 hours, it can be given, and doxycycline can be given to complete the 2 weeks therapy. Now, when do we give intramuscular therapy when patient is not able to tolerate? Then we can give ceftriaxone IM single dose plus doxycycline twice a day with metronidazole or cefotetin single dose plus doxycycline with metronidazole or other third generation cephalosporin and doxy and metro together. Now, the question comes whether we should give the patient intramuscular or oral treatment. We can give the patient IM or oral therapy depending on the severity of PID in cases of mild to moderate. But when a patient who does not respond to IM and oral therapy, we have to reevaluate and confirm the diagnosis. Now, there has to be a coverage against frequent etiologic agents for PID. The optimal choice of cephalosporin is, as per the guidelines, is unclear. Cefotetin is second generation cephalosporin, has better anaerobic coverage than ceftriaxone. It should be preferred. Ceftriaxone has a better coverage for N-glycerol and gonorrhea, and additional metronidazole provides extended coverage against anaerobic organism. Alternative intramuscular and oral regime as a result of emergence of quinolin resistance and gonorrhea. The regime that includes quinolin agents are not recommended. However, if patient has cephalosporin allergy or individual risk of gonorrhea are low, then we can easily give them quinolins. In quinolins, levofloxacin, moxifloxacin with metronidazole is very preferred drug. Or we may give patient azithromycin along with metronidazole. And moxifloxacin is, of course, preferred for M. genitalium infection, and we have the importance of covering the M. genitalium infections in the patients. There are other, additional therapies we have to give to the patient, like supportive therapies like antipyretics, analgesic, and proton pump inhibitor. Because these drugs lead to a lot of nausea and vomiting, so we need to add the antibiotics also. Then, very, very important to guide the patient that she has to abstain from, from intercourse until the therapy is complete and the symptoms are resolved and the sex partners are treated. It is very important to treat both. Percutaneous drainage is done in cases where there is a very large abscess and there is no improvement in 48 to 72 hours. The success of treatment is 70 to 100%, but there are no trials or data available. Advantage, of course, it avoids associated general anesthesia and surgery. Disadvantages that if it is not effective, if the collection is multiloculated, and it will take longer time to resolve. which are, the cavities which are not, which may not be able to reach. And ideally in acute cases, we have to avoid intervention, although if possible. Many patients with tubo-ovarian masses will eventually need surgery, and delay of 2 to 3 months may be very damaging. So this is a beautiful chart I got, which shows that the delay in surgery of 2 months can, it can be there when there is any indication of surgery there, when the diagnosis is unclear, there is percutaneous drainage not possible, or patient is decompensating and there is no improvement in 48 to 72 hours. And if she is stable, future fertility is desired, then we have to attempt to preserve the uterus as well as the ovaries. And if there are symptoms or pelvic pain and fertility requiring IVF, then we have to do bilateral salpingectomy and explantation, or depending on the goals of what expected management accordingly. So coming to the end, when do we do the follow-up? It is very, very important that patients should have an improvement within 3 days of therapy. And if there is no clinical improvement, hospitalization, assessment of antimicrobial regime, additional diagnostic, including considering diagnostic lab and alternative diagnostic like NAT, etc. are recommended. Now, it is very, very important to test the woman after 3 months, because all women who have received a diagnosis of chlamydia and gonorrhea PID should be retested at 3 months after treatment, and regardless of whether their sex pattern has been treated, or if retesting at 3 months is not possible, then the woman should be retested whenever they next seek the medical care. That means less than 12 months after the treatment. Now, so many times, patients ask, what about my partners? We all know that we have to treat the partners of chlamydia and gonorrhea, regardless of etiology of PID or pathogenesis associated. And pregnancy is another very common problem, where if a pregnant woman is suspected to having PID, because they are at a high risk of maternal morbidity and preterm delivery, they should be hospitalized and treated with IV antimicrobial. Now, coming to one of the cases, what about IUCD? We all know that risk of PID associated with IUD is confined to first 3 weeks after insertion. If IUD does not, the IUD does not to be removed. If it is infection has occurred after that, and if there is no clinical improvement within 48 to 70 hours, of course, we need to reconsider removing the IUCD. Now, how do we reduce the risk of PID? It is very, very important for us that we need to screen and treat chlamydia and gonorrhea and EV and genitalium associated with PID. And role of screening and treatment is, of course, very, very unclear as per guidelines. So to give, recapitulate important things. Dr. Nishu, can you mute yourself, please? Dr. Nishu, please mute yourself. Admin.
Dr. Nishu, please mute yourself.
Please mute yourself. Thank you. So to recapitulate.
Yes, ma'am.
Yeah, mute.
Actually, I think there's a network problem
muted
at my side, ma'am.
Dr. Nishu, you're not muted.
Okay, ma'am. Let me.
Yeah.
Thanks. Keep a low threshold of clinical diagnosis of PID. Control the infection energetically. Give anaerobic coverage. Complete 14 days treatment and treat the partner. Follow up after 3 days, and retesting after 3 months is very, very crucial. Thank you very much.
Thank you, madam, for the wonderful deliberation. Extensively discussed all points. So may I now request Dr. Kiran Arora, ma'am, President, Gurgaon OBGY Society, to give her closing remarks.
Thank you, Dr. Pratibha, and thank you, Dr. Supriya, for making me part of this nice webinar. Dr. Anju Soni has covered the topic of medical management of PID wonderfully. She's touched upon all the points, and the PID approach, the 5 Ps, is really interesting. Partner, practices.
There's a power
I think he
failure.
has some problem with her band.
No, I think that there's a power fail, no? So
Power failure there.
yeah, looks
Yes,
like.
yes, yes.
Yeah.
So meanwhile, can we
Yeah.
request Dr. Nishu Gupta to give her comments?
She has come.
Yeah. Yes, madam.
Yeah, she's there.
And of course, give a complete course of treatment, 3 days follow-up to review the treatment is effective or not. And after 3 months, again, a follow-up. So we need to communicate with our patients the importance of prevention. If at all they are sexually active and all that, so that aspect also needs to be touched. Medical management treats many a cases if given well in time, because we all know that the scarring and the damage done to the genital tract by PID is not reversible. So early management is the key to success, to prevent sequelae of ectopics and infertility and all those things. Thank you, Dr. Anita Soni, for a wonderful talk.
Dr. Anju Soni.
Anju Soni, sir.
Yeah, thank you. But I just wanted to add one more thing, which I did not put on in my presentation. Then, it is very, very important. We have to give Metrogyl to all the patients. And we have to tell the partner not to consume alcohol because, then the side effects, the effect increases of the alcohol. So that has to be avoided, which I could not write, of course, in my presentation, but it is very, very important and we have not to miss this.
What is your take home, madam, regarding the high vaginal swabs taken for anything?
Basically a simple saline is a very good thing. For PID per se, vaginal swab is not, it's for vaginitis, yes, it is very effective. But for PID, it may be effective, it may not be effective because we will not be able to see gonorrhea and all those organisms. So it's mostly clinical along with the, other signs and symptoms, additional signs and symptoms. That is what can take us near to the diagnosis.
Yeah. Thank you, madam.
So
Excellent.
may I request Dr. Nishu Gupta also to give her some inputs? She is there as a chair.
Nishu has, turned off her video also, I think.
Yeah.
Dr. Nishu?
Dr. Nishu?
She was asked to mute and then she turned off her video.
She muted and she is video also.
So with this, we come to the end of the session. I thank the wonderful speaker, Dr. Anju Soni, madam.
Before muting myself, I want to wish everybody best wishes for your, elections. All of you are the most deserving people.
Thank you so much,
Best wishes.
Thank you.
Talk and wonderful wishes.
Thank you.
And I thank the chairpersons also for this session, Dr. Kiran Arora ma'am, Dr. Nishu Gupta, and Dr. Sudesh Agarwal. So we're moving on to the third session. We have Dr. Pratibha Singh as the speaker of the third session, who is also contesting for International Academic Exchange Committee, FOXI, as chairperson. So to chair the session, we have Dr. Kiran Chandana madam. So she is President Faridabad OBGY Society, member FOXI MTP Committee, special interest in adolescent health and contraception. She is active member of FOXI and her OBGYN, Haryana OBGY Society, contributed articles in various journals, work experience of more than 35 years, and she is director of Chandana Medical Center, Faridabad. Welcome, madam. So the next chairperson is none other than Dr. Poonam Lumba, madam. She is chairperson, Haryana chapter of ISAR 2011-15, executive member ISAR, honorary librarian ISAR, clinical secretary ISAR 2020 till date. Then AOFOG, general secretary, Haryana chapter of IIG, ex-president IMA, editorial board journal, president Society of Obstetrician and Gynecology of Ambala, FOXI, director of Lumba Hospital and IVF Center, and she has been awarded with many awards, President's Gold Medal at university level. She has got many achievements as first IVF center in Haryana, trained in Harvard in advanced ultrasound and fetal medicine, and she is a very, very active member of FOXI. So welcome, madam. The next chairperson is Dr. Pradeep Bandwal sir. So he is Secretary Udaipur OBGY Society, Medical Director Narayani's Women's Hospital and Fertility Center, Udaipur. He is ex-faculty, has been the ex-faculty in OBGY IVF department and Civil Hospital Ahmedabad, IVF consultant, Parul's Women Hospital, then former Joint Secretary UOGS, then Organizing Secretary of West-Zone Yuva Foxy, Organizing Committee member and faculty Urogynec 2015, 16, 17 and 18. So he is a very active member. So with these words, I welcome all the chairpersons. And to introduce the speaker, Dr. Pratibha Singh, may I request Dr. Poonam Lumba, Madam, kindly introduce the speaker, Dr. Pratibha Singh. Over to the chairpersons.
Yeah, good evening, everyone. So it is very nice to be part of this webinar today. Dr. Pratibha Singh is going to talk about multifetal reduction today. So I'll just read out her CV. She is a consultant laparoscopic gynecologist and IVF specialist, Director Healing Touch Multi-Speciality Hospital and IVF unit at Bhagalpur. She has been National Coordinator for IAEC Foxy 2021-2022, and she has a specialized training in reproductive medicine, diploma in IVF, then past State Honorary Secretary General, EOGSPJ, Founder Secretary, Society of Vaginal Surgeons of India, and she has been organizing secretary for many conferences. So over to Dr. Pratibha Singh for her talk.
Thank you, madam, for wonderful introduction of mine. Can I share my screen?
Yes, ma'am.
Meanwhile, Madam Dr. Kiran Chandra is also there. Can you, Madam, may I request you to talk something on the subject? Fetal reduction in multi. Yes, Madam.
Okay, ma'am. Thank you, Dr. Supriya, for inviting me for this, attending this webinar. Very informative. And I think this is a very important topic because in IVF and during multiple pregnancy, we are going to have multiple pregnancy, which is going to affect the impact on the fetus and both the mothers. So to save the mother certain medical diseases and also the effects of multiple pregnancy and the fetus from the certain defects, cerebral palsy and premature delivery, we have to get it. It is very important to do fetal reduction for this patient. Patients, and I think it is very important topic. And best of luck, Dr. Pratibha Singh ma'am and Dr. Supriya, for your coming in elections.
Thank you, madam. Thank you so much, madam. Can you hear me? Hello?
Yes, ma'am. Yes, ma'am.
Can you see my screen?
Ma'am, your screen is seen, but not in the slideshow mode, ma'am.
Okay. Now can you see?
Yes, ma'am. Yes, ma'am. Perfect, ma'am.
So, good evening to all of you. First of all, respected chairpersons and my dear friends, a very good evening to all of you. And first of all, I would like to thank you all for giving me this opportunity to address such galaxies of speakers here. So thank you so much. And today I'll be talking about a very pertinent subject. So I thought I will start with this picture where you can see the eager patients waiting to have babies somehow and the overzealous doctors busy making babies without realizing that the result can be this, that is multiple pregnancies, especially for those who are trying for pregnancy since long and have become pregnant with such disaster. So I don't think this is a happiness. And the difficult part is that when you have to choose best from among the worst option, So that is a very fluid condition. And this is the first quintuplets known to survive till infancy, but then this was their fate. All are not so lucky. So prevention is better than cure. And today I am going to talk on the fetal reduction in multiple pregnancy. Now, fetal reduction technique has emerged as a very effective medical approach to improve pregnancy outcome and key option of the patient trying to carry pregnancy till term in the multiple pregnancies. And we all know that the high order fetuses have a worst outcome both for the mother as well as for the babies. But still, this is a very difficult topic to discuss and talk, as it takes strong will and emotions as a part of doctor and the patient to take certain decisions that is best for mother and child, especially for those who are infertile for such a long time and craving for babies. Also, we must understand that it is performed with the intention not to induce abortion, but to preserve the life of remaining fetuses and minimize the complications to the mother and fetus. Because we all know that the perinatal mortality in terms of in singleton pregnancy is around 9.7 to 1,000 live births, which increases to 52.7 per 1,000 live births for twins, and which further increases to 138.5 per 1,000 live births for triplets. So you can see huge difference if you reduce triplet to twins and twins to singleton. Now, these are the few terminology which we should be knowing, that what is multifetal pregnancy reduction. That is the termination of one or more high order fetuses, hopefully leaving the rest to develop to full term. Whereas selective fetal reduction is when we are reducing the fetus with severe malformations or congenital defects, or which is expected to die later in pregnancy, or which would threaten the life of the surviving fetus or fetuses. Then spontaneous fetal reduction or resorption, usually 90% occurs up to 7 weeks, and it never occurs after 13 weeks. And once the fetal heartbeat is visualized by ultrasound, the reduction is almost 6%. So usually the fetal reduction is done once fetal heartbeat is visualized by ultrasound. So over the decades, for last 20 years, high order multiple pregnancy has increased more than 100-fold due to ART and fertility drugs. We all know that. But of late, the efforts have been made to prevent this by judicious use of gonadotropins, which can promote monofollicular development, and also by promoting single or at the maximum double embryo transfer. But still, there is a significant high in the twin pregnancy. Now, if you trace the history, fetal reduction was started in 1980s to salvage the pregnancies of couples needing ART and who were finally successful, but with too many fetuses. Now, this procedure was somewhat controversial from the beginning and drew some attention from anti-abortion activists. But then, where reducing to zero is permissible, especially in those countries where the MTP or medical termination of pregnancy is legal, what is wrong in reducing high order to lesser number? So a set of ethical guidelines were developed in collaboration with bioethicists from NIH, and it was published in 1988, which justified reducing pregnancies with more than 3 fetuses to 2 or 3. Sex selective reduction is still considered unethical. Now, those females who have to undergo this fetal reduction, there are a lot of issues, like they will be asking why we should go for this fetal reduction when we were not able to conceive, and now we have conceived with so many babies, so why we should go for that? Then if they have agreed, then when it should be done and how it should be done. So we must counsel our patient that it is mainly because of the maternal risk. We all know that high order multiple pregnancy may result into a lot of problems like hyperemesis gravidorum, anemia, diabetes, PIH, and the most common is the preterm labor or preterm deliveries, because it has been estimated that the average length of pregnancy for singleton pregnancy is 39 weeks, which reduces to 35 to 38 weeks for twins, For triplets, it goes down to 30 to 33 weeks. And for quadruplets, it is 28 to 29 weeks. So it becomes really difficult preterm delivery and the babies will have a lot of problems. Along with this, patient may have the history of abruptio placenta, increased chances of cesarean section and postpartum hemorrhage. As well as fetal risk is concerned, increased chances of miscarriages, acute polyhydramnios. Then due to preterm delivery, there may be low birth babies with the significant short-term and long-term health problems. Now in this chart, you will see that for twins, the average gestational age for delivery is 35 to 38 weeks with survival of 98% and impairment of 5%. Whereas for triplet, the average gestational age of delivery is 30 to 33 weeks with survival of 85% and the impairment of almost 10%. Whereas for quadruplet, the average gestational age of delivery is 28 to 39 weeks with survival of almost 70% and impairment of as high as 50%. So this is the problem with the multifetal pregnancies. Now, even the birth defects in monozygotic twins are also more likely than that of the dizygotic twins, which are born with the congenital malformation. Then cerebral palsy can also occur, which may cause a permanent neurological damage. Then infant mortality, especially because of the premature delivery. So mostly which occur when the gestation is less than 32 weeks and the birth weight of the baby is less than 1,500 kg, 1,500 grams. Now, in the premature birth, there may be increased chances of RDS, and it has been seen that almost 50% of neonatal deaths occur because of that. So fetal reduction is widely accepted in the quadruplets and high order multiple pregnancies. Although twins, generally it is not acceptable, and in triplets it is controversial. But the recent advances says that reduction may reduce the risk of severe prematurity, neonatal morbidity, and the cost of care per survivor. Because once the preterm babies are born, then they have to be kept in the intensive ICUs, and that will increase their financial burden. So it is better to reduce such pregnancies. Even FIGO recommends that it is ethically preferable to reduce the number of fetuses rather than to do nothing. Now, before doing fetal reduction, you must counsel your patient, the couple, very nicely, because there may be the risk of miscarriages and you must have informed consent. RH status should be taken. Then ultrasound should be done prior to fetal reduction to know the number, location, size of the fetus, gestational sac. Then the fetal heartbeat should be confirmed in each fetuses, and any signs of fetal abnormalities should be detected. Then you must determine the number of fetuses to be reduced. Then which sac can be reached easier with less trauma should be selected. Then approach and timing is between 7 to 12 weeks. If transabdominal approach is taken, then it is between 10 to 12 weeks, whereas for transvaginal approach, you can do it a little bit at the lower gestational age, that is 7 to 9 weeks. So 8 to 9 weeks looks to be optimal, because later it will be more difficult and there will be less probability to spontaneous fetal resorption. Now the approach is again transcervical, which was first attempted before. Then transvaginal reduction, either by KCL injection or by cardiac puncture. Transabdominal reduction by KCL, and the transabdominal radiofrequency ablation. This is the newer technique. Under US guidance and aseptic precaution, the selected fetus is approached transvaginally or abdominally with 19 or 21 gauge needle, and exact alignment done, and most easily accessible fetuses are selected for embryo reduction. Or alternatively, you can go for those embryos which have a small fetal sex, or those embryos which are located close to the fundus, so that it will decrease infection and bleeding. So the fetus which is reduced can be done by cardiac puncture, or you can do the aspiration of fetus if possible, or you can just puncture the heart till the asystolia is confirmed, or you can give intracardiac or intrathoracic injection of 1 to 2 ml of potassium chloride. So after ensuring that the fetus concerned has been completely aspirated or there is no fetal heartbeat over 1 minute, then the needle is withdrawn. So there are many studies done regarding which approach is better, transcervical versus transvaginal approach. Now, transcervical approach was initially tried, but with little success, and it was concluded that the transcervical aspiration should not be done because it carries more miscarriages and more loss of fetuses. Now about transvaginal versus transabdominal approach. So of late, transvaginal approach is becoming more popular as most of the fetal reduction is being done by the ART specialists who are more comfortable with the vaginal approach. But the only disadvantage with this is that it has to be done between 7 to 9 weeks, and sometimes it may result in miscarriage. And also you require an expert hand for that. Whereas for transabdominal approach, it is relatively easier procedure and have short learning curve. The advantage being here is that the miscarriage rate is less, and also you can combine this with the second trimester screening. Now this is another study which was done where they compared transabdominal versus transvaginal approach in terms of miscarriage rate. And they found that the miscarriage rate after transabdominal procedure was half as compared to transvaginal approach. Now, transvaginal cardiac puncture is supposed to be the superior procedure in expert hands, and it has been found that take-home baby rate is around 89.5% for twins and 80% for singleton pregnancies. So it is better procedure approach, but then it requires a lot of expertise. Again, this was a comparative study where they have compared pregnancy outcome for the methods of multifetal reduction for the babies, and they found that the non-KCL groups showed a significantly higher take-home baby rate and the lower risk of extreme prematurity and preterm premature rupture of membrane than the KCL group. And in that, the early non-KCL group was better than the late non-KCL group. So they concluded that the early non-KCL method may be the better option for multifetal pregnancy reduction. Now, what about reduction versus no reduction? So it has been found that for the high order multiple pregnancy, if you do the reduction, then the pregnancy will have then prematurity will be less, those babies who are surviving, birth weight will also increase, and the perinatal mortality will also reduce. So reduction should be done in high order multiple pregnancies. The overall success rate is around 80%, which can be improved by increasing experience, better ultrasound facilities, lowering starting number, and genetic diagnosis prior to reduction. Now, risk is mainly operator dependent. So less experienced operator have to have worse outcomes. So you have to learn this technique. It looks very simple, but you require expertise in this. Then only you must go for this. There may be chances of PPROM. There may be chances of chorioamnionitis, miscarriages, preterm delivery, and sometimes there may be vanishing fetuses also. Now, this is the newer high-tech technique, which is mainly reserved for the TRAP trap, which is a rare complication of the monochorionic twins. And here the radiofrequency ablation involves the coagulation of the tissue induced by temperature changes through a high frequency alternating current. But then it requires this device and it is not available everywhere. Alternatively, if the ablation is contraindicated, then an easier technique is there where the fine needle amniotic fluid aspiration and the injection of 10% sodium chloride into Wharton's jelly, which involves selective reduction of the acardiac or acephalic fetus in monochorionic twins, can be done, which is technically easier and cheaper. Now, what about fetal reduction in monochorionic twins? So this paper says that there 80 cases were included in this study, and out of which 73 were twins and 7 were triplet. And they found that there was 9 intrauterine deaths, out of which 5 were within 24 hours and 4 were between 4 and 10 weeks after the procedure. And they found that the mean gestational age at delivery was around more than 32 weeks. and the babies who have survived, or the children who have survived, the children have a normal development till 1 year of age. Complications we all know with fetal reduction: miscarriage is as high as 7 to 8%, chorioamnitis 1 to 2%, preterm delivery or PPROM, if it is less than 36 weeks, then it goes to 40%, and very rare vanishing fetuses. So by public health perspectives, fetal reduction needs to be seen as a necessary step and effective option for women with high order multiple pregnancy. Over past 25 years, data from around the globe have shown that the pregnancy outcomes are vastly improved by reducing the number of fetuses in multiples. Then fetal reduction by transvaginal route without using cardiotoxic agent like potassium chloride may be more promising. And data suggests that even the reduction for twins to a singleton improves the outcome. But then you must counsel your patient properly, because small percentage of cases there may be total pregnancy loss. And also it is a very worrying issue as an ethical one, and that can never be universally accepted, because women receiving fetal reduction usually encounter difficult decision and tremendous emotional stress, especially those who are infertile for long and those who are craving for baby. So multi-fetal pregnancy, particularly high order multiple pregnancy, should be prevented in first place by judicious use of gonadotropin, by the promotion of single monofollicular development of the for monofollicular development, and also by promoting the single or the maximum double embryo transfer. It should never be considered as a standard line for prevention of high order multiple pregnancy. Like you should not be transferring for 3 or 4 embryos just because we would think that if it will be triplet or quadruplet, we will do fetal reduction in the later time. It should be only a rescue procedure if other methods fail in prevention. And should high order multiple pregnancy occur in spite of all preventive measures, then fetal reduction may be performed applying the jurisprudence principle and the choice of the lesser harm. Till then, we continue to hope that we have a better controlling ovulating agent and better ART facilities, so which make multi-fetal pregnancies uncommon and just obsolete this procedure, this reduction procedure. So thank you for patient hearing. I think
Thank you, Pratibha.
Thank you so much.
Yeah, I just missed out on the lecture a little bit, but we all understand that multi-fetal reduction came into practice only after multiple embryos were getting transferred. And since the new law is being enforced, we all know that we cannot transfer more than 3 embryos. So in practice also, we have seen that almost like for the last 3-4 years, we have stopped doing reductions because the number of embryos being transferred is never more than 3. And with the blastocyst transfers, we are getting normally singletons or twin pregnancies. For triplets, it's always debatable. Thank you so much, Pratibha.
Thank you, madam.
Can I request? So yes, can I request Dr. Kiran ma'am to give her also comments, closing comments? Dr. Kiran Chandana ma'am.
Yeah.
Hello.
Yes,
it has been a very informative talk, and you have covered all the aspects, all the ethical aspects, emotional aspects, and how to do it. And the counseling of the patient is very important, and you have elaborated to use how to use KCL or the non-medicated methods, new methods you have told to us, to the general practitioner, so that we can at least refer these patients for, if the patient comes to us, we can tell them these things are possible. For general practice point of view, these are very important to us. And you have told us about the transvaginal route and transcervical route of this method. And I found it very useful, and it was new to me. because I have just listened from the patient because I have not attended such conference, but it was very useful to me. And because in general practice we are doing just the general gynecology, and this may not be new to the practitioners, but it was very useful for us general practitioners. Thank you.
Thank you.
Thank you.
Thank you, madam.
So thank you. We come to the end of this session, and I thank the speaker, Dr. Pratibha Singh Madam, and the chairpersons, Dr. Poonam Lumba and Dr. Kiran Chandana Madam. So very nice session. Now we come to the power-packed panel discussion. So the topic is on GDM. To moderate, we have two expert moderators. Can I have the CV? So going to be a very interesting panel now. Dr. Suman Sinha, she is Senior Consultant OBGY at AHIVF and Infertility Center, Morabadi, Ranchi. Then she is ex-Chief of Medical Services and HOD OBGYN at CCL Hospital, Ranchi. East Zone Coordinator Medical Disorders in Pregnancy Committee of FOXI, President Ranchi OBGY Society, Convener Public Awareness Committee, Secretary Ranchi OBGY Society in 2005-7, Vice President SOFSI Bihar and Jharkhand Chapter, Executive Member, National ISOPA, President and Secretary ISOPA Ranchi Chapter in 2014-20, invited faculty in many conferences, publications to her credit are there. She has been the organizing secretary. She is the organizing secretary of East Zone UA FOXI conference to be conference Ranchi 2005. She was then organizing chairperson ISOPA midterm conference, and she is trained in laparoscopic surgery and has many awards to her credit, like Dr. Duru Shah Appreciation Award for Growing Up programs. So with these words, I welcome you, Dr. Suman Sinha ma'am.
Thank you.
And the next moderator is Dr. Kanchan Sharma. She is Secretary Kanpur OBGY Society, President IHRF Kanpur branch, then past Vice President at IMA Kanpur, laparoscopist, colposcopist, ART specialist. She is the Director Akash IVF Center Kanpur, speaker and chairperson in many national and international conferences, recipient of Pratigya Social and Empowered Women Award. She is also contesting for chairperson study of female breast. All the best wishes to Dr. Kanchan Sharma and to Dr. Suman Sinha ma'am. She is contesting for the chairperson CRC Clinical Research Committee of FOXI. With these words, I hand over the platform to both the moderators.
I'll request Dr. Supriya to kindly introduce the panelists also.
I think Dr. Suman was going to do that, no?
Okay, you can do Dr. Supriya. It will be better for me.
Okay, so to introduce the panelists, we have Dr. Vidhu. She is consultant and director at Suman Hospital, New Life Test Tube Infertility and Research Center. Then she has got many affiliations, like she is the president of Ludhiana OBGY Society, member of Inner Wheel Group, member of Food and Drug Committee and Perinatal Committee. Awards she has got Best Student Gold Medal in Surgery, and she is working as fertility expert since last 20 years in New Life Infertility Center, obstetrician and gynecologist at Suman Hospital. She has got special interest in infertility and high risk obstetrics. She's been trained in many FOXI ultrasound course and others. Welcome, Dr. Vidhu. Next, Dr. B.S. Jodha sir. He is professor and Dr. SN Medical College, Jodhpur, Rajasthan. He has been awarded as diploma in gynaecoscopic surgery, trained in ultrasonography, secretary of Jodhpur OBGY Society, Marwar Achievers Award in 2015. He had been done his postgraduate and undergraduate examiner. He is the postgraduate and undergraduate examiner in various universities in India. He is the national master trainer of various government sponsored programs, various publications to his credit. So welcome, sir.
Welcome, Dr. Jodha. Welcome.
Then Dr. Subhori Rizvi, she is the Secretary Gurugram Obs and Gynae Society, trained in adolescent health in Narchi, certificate course contraception in clinical practice, more than 23 years of post-PG experience, director Mother's Clinic and Ultrasound Center, worked as fetal ultrasoundologist in government and private setups. She started Heal India programs for adolescents and their parents. then conducted workshops for adolescent teachers and parents. So welcome, Dr.
Welcome,
Yeah. And the next chairperson is none other than Dr. Manoj Chelani, sir. He is the he is contesting for the Medical Education Committee, FOXY. Then all the best to you, sir. And he is from Raipur OBGY Society, a very active member. He is the backbone of this CME, this web series, what is going on, the Knowledge Bytes. Welcome you, sir. Next, Dr. Ashish Kale. He is director, Asha Kiran Hospital at Pune, Asha IVF Center, Pune, director, Arunachal IVF Center, vice president, Pune OBGY Society, librarian, Maharashtra chapter of IAG, and executive member, National SR, chairman, AMOX Infertility Committee, executive member, Maharashtra SR, and he is Champions of SR Award. He has been recipient of that, and treasurer, Maharashtra chapter SR, peer reviewer of Suffolk Journal, recipient of Kamini Rao Oration Award, FOXY Future Award, and Young Achiever Award, Pune, Young Researcher Award. So with these words, I welcome you, sir, Dr. Ashish Kale.
Thank you, madam. For family welfare.
He is going for Family Welfare Committee of FOXY. He is going
all the
for
best.
elections. All the best to him.
Require blessings from all, madam. Thank you.
Yeah. So next is Dr. Chanchal Gupta. She is HOD and consultant obstetrician and minimal invasive gynecological surgery. She is educated.
She's not able to join.
Oh, acha. Okay, then she is secretary of Faridabad OBGY Society. Has she joined?
No. She has given a message that she is not able to join. She is
okay. Then we move ahead.
Vidhu, I don't find her. Is she there?
Okay.
Yeah, she is also in emergency. Actually, she could not join.
Okay, then
Natsu and Dr. Chanchal both are busy.
Then move ahead.
Only 5 panelists.
So Dr. Sapna Jindal, is she there?
Sapna?
She's secretary of Palwal, consultant.
Yes,
and
she's there. She is there. Yeah. Anmol Hospital. Yeah.
So Anmol Hospital, I welcome you, Dr. Sapna Jindal. So with these words, I invite all the panelists and we look forward for a very power-packed and interesting panel discussion. Over to the moderators.
Thank you, Dr. Sapna. I just want to look. Dr. Sapna is also not visible. I think she is in delicate.
Anmol Hospital, no, madam. Anmol Hospital.
She's there.
Okay.
So,
welcome, Dr. Sapna.
Thank you, Dr. Supriya, for the very kind and generous introduction of ours. And now, after the very mind-blowing and very crisp and very informative deliberations by our very esteemed speakers, we move on to another very exciting, thrilling, and very informative session on GDM. And you know,
the panel starts from Dr. Suman. She'll be
I'm
starting the
going to
session.
welcome you also, Dr. Kanchan. But first, let me, share my slides. Can you see my slides?
Yeah.
Yes. Yeah. So I have to do the this thing.
Full screen.
Yeah, I'm doing it. Just a minute. Okay. Now it's okay?
Yes, ma'am.
Yeah. So again, a very good evening to everyone. And thank you, organizers, for giving me this very wonderful opportunity. And with this, I welcome my co-moderator, Dr. Kanchan Sharma, who is very knowledgeable, ever smiling, very enthusiastic. And I also invite her. And after that,
thank you, Dr. Suman, for your wonderful words.
Thank you. My pleasure. And now I am very excited to introduce to you my very vibrant and very enthusiastic and very knowledgeable panelist, though I'm missing Dr. Bithu Modgil and Dr. Chanchal Gupta also. But then I will request all the esteemed faculties who are present here to join this very exciting panel on GDM.
because you know this is the need of the hour, you can say. कहते हैं ना एक जांच बचे दो जान, and this word is very very close to my heart. So let us move on to the panel. I welcome everyone here to be in this panel. Dr. Jodha sir, Dr. Subbohi, Dr. Sapna, Dr. Kale sir, Dr. Mano sir, and everyone present here. So with this, I move on to a saying by Mark Twain: good decisions come from experience, and the experience comes from making bad decisions. It's really very true. So what is this hyperglycemia or GDM in pregnancy? As we all know, 6.2 million live births are affected by hyperglycemia in pregnancy, of which 5.2 million are due to GDM. So regarding its definition, it is defined as carbohydrate intolerance of variable severity with onset or first recognition during pregnancy, because pregnancy is a form of stress that can cause latent diabetes to manifest. In most of these cases, the carbohydrate intolerance will revert by the end of the puerperium, but this manifestation may be the first indication of diabetes yet to come. So regarding the incidence, we all know the incidence in United States is 2 to 5%. Among the Asians, it is very high, 8%, and it is higher in India, it is 14%. In the urban population, it is more high, it is 17.8%, and in the semi-urban population, it is 13.8%, whereas in the rural population, it is not less, it is also near to 10%. So, since Chanchal Gupta is not present here, so this question goes to Dr. B.S. Jodha, sir. Sir, why is pregnancy diabetogenic?
Yeah, so good evening to all. We had a very good discussion of earlier topics, and there's a good topic of GDM has been to it. Because all we know that these, the situation in the pregnancy, which is a adaptation from a natural pregnancy phenomena and various types of placental hormones, which are working on the patient's body, which makes the difference, especially the cortisol and progesterone, and the other hormones like human placental lactogen, estrogens, leptin, adenolactins. These are also working on the placenta, secreted from the placenta. They are having effect on the patient's body. They make the changes in the milieu of the mother. If the adaptations are very good, then the mother can tackle it, the situation. If the pre-existing something high risk in form of other risk factors, then the risk may grow and the patient may be precipitated in form of carbohydrate intolerance. So these are the few things which makes the pregnancy as a diabetogenic, and we should be cautious enough to pick up it as early as possible, right from this end of first trimester, and then it can be confirmed in second and third trimester also, that we have not missed these things earlier.
Yes, sir. Thank you so much, sir. Actually, during pregnancy, this placenta, it produces the insulin antagonists, sir. Yes. And these antagonists and the insulin in the normal, I mean to say non-diabetic patients or patients with a good glucose tolerance, they keep both of them in balance. But in the patients who are going to be diabetic or a poor intolerance of the carbohydrate, the insulin resistance goes up, and the sensitivity to insulin in the tissues decreases. And this is the reason why this pregnancy becomes GDM. So there is marked increase in the peripheral resistance to insulin. Insulin becomes less effective there, and suppressing gluconeogenesis, and decreases peripheral utilization, which will cause increased plasma level of glucose. And GDM, we have then GDM and its complications. So another question again is to Dr. Vidhu. So this will again also go to Dr. Jodha sir only. So we start with the first case because you have answered a part of it, sir. She is a 34-year-old lady. She is married since 4 years, and she is in a very first pregnancy. And this pregnancy is very, very precious because it is by IVF, and she has come to you for the first antenatal checkup, and that also at 10 weeks. Her family history reveals that her mother has type 2 diabetic mellitus. So, sir, I'm bombarding the questions to you, but the answers will come by one. So, sir, what are the risk factors for GDM?
So the patient who are having these types of problems, which are late marriages or the previous history of PCOS or family history in siblings or in parents or maternal side, there are risk of having these problems which may manifest in such pregnancies. So which patients who are obese or Asian ethnicity, they are at risk of developing these are type of these are the risk factors which may make these patients to be at high risk zones. So we have to be cautious enough right from the beginning to pick up these early and to prevent the complication to mother and other.
Right.
So, and the various histories of losses if they are having. In this patient, is a first case. Otherwise, the patient who has lost or unexplained IUDs at term or any type of abortions which has happened. So these are the few complications which these patients may suffer during their pregnancy period, which may be complicated by the preeclampsia and risk of having macrosomia, diabetes, or birth trauma, or maternal injuries during cesarean sections or during normal delivery, shoulder dystocia. These are various complications if the patient who has already delivered and face these problems.
Yes, very rightly said, sir. So, is Dr. Subohi there?
Yes, ma'am.
Okay. So, this is another question. Is screening required in this patient? And which type of screening you like to offer to your patient? And how will you perform this screening?
Okay. First of all, ma'am, thank you so much for inviting me for this panel. And it's indeed a good learning experience to revise and re-revise and ultimately get more confused also. So, because by the end of the evening, it is like that. Okay. So screening is definitely required because of the history that the mother is having that's the first degree relative is having a history of diabetes. Second, she is IVF conceived. Second is advanced maternal age towards 34 side. So all these three things, and in spite of all these things, there is now by WHO universal screening has to be done anyways. So she lands up into high risk as well as the universal screening category. For us, there now initially it was like that when we were doing internship, it was like one screening has to be done at 24 to 28 weeks. Now it is like whenever the patient comes to you first in this thing, you can give a glucose challenge test in that screening itself. So now it is like a universal screening, and then you can just see if the glucose, like if the 75-gram glucose test that is like dissolved in 300 ml of water and given in 10 to 15 minutes time, if the sugar level turns to be 140 milligram per deciliter, then she is GDM, and then you can just see that whether you have to put her on the MNT as well as the exercise schedule, and see.
We'll learn later. MNT and everything.
But in this case, the one thing that is tempting to me, because I do a lot of ultrasound, is that I will definitely do a TVS at 10 weeks itself to see if I can just see anything that will help me out. So that's there.
Yeah, that's come under the management part. This was only about the screening. Yeah. But you rightly said that you have to screen the moment patient reaches to you, and it should be, if it is in the first trimester, it is the best because you can pick up more.
Then you can do that.
So now even if you can pick up the pre-gestational diabetes in such patients, if you are doing it right at 10 weeks, there may be group of patients who has been missed earlier.
Yes, otherwise you could have missed these cases.
Yes. So now they are like 2-point screening is there instead of 1 by WHO saying that.
WHO, but we are following only one-step testing. No, this.
I read this today, so I was like, I'll forward you the PDF.
I have put it there. You know, the later slides. So now we can come to know by both the information shared to us by Dr. Jodha and by Dr. Subohi that there are two types of risks. One is high risk, and we Indians are categorized in the high risk ethnic groups. No? So what are the high risk cases? These are the age, according to age, BMI, strong family history, and previous history of this GDM, impaired glucose tolerance, unexplained stillbirth, neonatal death, macrosomia, bad obstetrical history. And the low risk, and it also, we have just discussed now, belongs to the high prevalence ethnic group in present pregnancy. If there is infection, polyhydramnios, congenital anomalies, they are all the high risk factors for GDM. So the low risk cases and the high risk cases, we categorize the group into two, high risk and the low risk. That's all. So now the real question comes to you. At what period of gestation tests should be done, Dr. Subodhi?
Yeah. So as I was previously telling, now the test is done. Like previously, we knew that it has to be done at 24 to 28 weeks. Now the government says that do it at the first visit itself. And surprisingly, I had one patient today who came at 10 weeks with a fasting blood sugar of 153. I got the blood sugar repeated, it came to be 84. So at that time also, I should have done, like as early as possible, the first glucose challenge test can be done. And now government is doing that for the first catch. So now 24 to 28 weeks is the second test that can be, the two-step test can be like done. That is the thing that is being normally.
We are doing the DIPSI test, that is one-step test only, and that is accepted, and that is under guideline of government of India also. That is with the 75 gram glucose, and 2 hours later we do the blood sugar.
Yes, 2 hours later, and if it is more than 140 milligrams.
What you wanted to tell us about the two-step test, and this is the guideline of the ACOG, where we do the GCT.
No, ma'am, sorry, it was not two-step which I wanted to tell, because we are not following this at all.
We're not following at all.
I was telling that in now the antenatal phase, they want you can do two tests instead of one oral glucose challenge test.
And
one whenever you see the patient first, because many times they don't come also, and many times you diagnose that, as sir was telling, that the pre-gestational diabetes and all you can diagnose, like the patient has come to you first time, and but in the antenatal, so
153 you were telling now, 153, maybe it was pre-gestational diabetic. Why it was first 2 hours glucose, it was 153 of your.
No, 140, like the same that is done there, the same is done before also.
I was thinking about your patient. You said na, she has come today with 10 weeks pregnancy and her this thing.
No, it is the same value in both the things, ma'am. That has been told, like the fasting glucose, this thing. So that is there. Sir may be a better person to guide you, but that is what.
She's saying in a right way, whenever the patient comes to us at the first time,
yes, ma'am,
that test is to be done at that time, that very time. If she comes late, even at 10 weeks, you have to do that test. And you have to repeat that test.
But at 24 to 28 weeks. So now they are like two glucose challenge tests are done instead of one glucose challenge test, which we.
So even if it is negative in the first test, then also you have to perform the second test.
Yes, that is very important. If it is negative, if it is positive, then you have to follow it like the way you follow it otherwise. So yeah.
So what are the Dr. Manoj? Sir, are you there? Manoj, sir? Dr. Manoj, sir, is there or not?
Yeah, he's there.
So I wanted to know what are the other criteria followed in the world. We are following the DIPSI criteria.
Yeah, we have made it very simple in a single test, and just not to.
Just the names, we should elaborate the names, sir. Because we should know what are the other tests.
Yeah, definitely. What is prevalent in the world, it is. But
so these are the tests done in the other part of the world. They are the NDDG group, which we were learning when we were students. We used to learn. AD Association, WHO.
We were mugging up these things earlier.
Yes, it was so confusing, and every time used to get confused.
And the worst thing is that yes, American is writing in millimoles and Indians are doing in milligrams. So one
That is another confusion, you know.
yes. So you read the first article in millimoles and then you read the articles in milligrams. So it is
Yeah,
another.
you have to. I have kept a calculator to convert.
Yes.
You know, every time I
So
convert.
Dipsy proved to be best amongst them. Therefore, we
Best.
have adopted that particular.
And we are so fortunate to have Dr. V. Sheshia with us because he's the first Padam Shri he got for his work and he really deserved.
Oh.
And yesterday we had a webinar I was sharing with EPCOG. I think Kanchan, Dr. Kanchan must be there.
Yeah.
And we had a very good lecture from him. I was really very delighted to hear from him, Dr. V. Sheshia. So, Dr. Ashish, you just explain us the procedure.
Yeah, good evening, everyone. I'm really thankful and thank you, madam, for giving me opportunity. I think when you are talking about the procedure, it is like what all of us was discussing is a DIPSI, what we do. So usually we ask the patient to take a 75 gram of a powder in 300 ml of a water, irrespective of the of a meal, where she can take any period of time. And 2 hours after that, the venous blood sample has been taken, and we interpreted it. If within a half an hour she vomits, then definitely we have to do the again the same 75 gram of a glucose has to be given to the patient, and then we interpret the DIPSI test. So this is usually for the DIPSI, and it is irrespective of the food or irrespective of what she has taken, or irrespective of the. So it is a universal screening.
Yes, sir. And the patient has to drink that glucose solution, I mean, within stipulated
5 to 10 minutes.
Yes, 5 to 10 minutes. That is also very important. And patient should be sitting at that place, not jumping and moving around and going to.
Yes.
That
Is it 5 to 10 minutes, sir, or is it 10 to 15 minutes?
It is 5
to 10 minutes.
5 to 10 minutes. 5 to 10. So because today only we have my patient, she came running to me. I said, I told you to sit somewhere. Now why you are coming to me? Sit there. So the benefits are fasting is not required. It has a good compliance because when you call now for fasting PPI, even like 2 steps, patient will not come. They come once, so they are brought from by their in-laws' house or even they are accompanied with their husbands, but they will not bring them twice if you ask them to come twice.
Exactly.
So the best test suitable to us also and to them also. And it serves as a screening and a diagnostic tool. And Dr. Manoj, let us interpret your DIPSI test. We want to know from you. How can we interpret?
So, ma'am, after like when we are given the 75 grams of glucose, irrespective of her fasting status, and then we see this thing, do the test again after 2 hours. So it should be less than 120 gram per deciliter. And if till the 2 hours, she should not take any meals. And then after meals, after 2 hours, it should be at less than 140. So if it's more than 200, then it's over diabetes.
Yes, if it is more than 200, it's over. It's clear cut, so easy to learn. If it is less than 120, it is normal. It is between 120 to 139, it is GGI. And if it is between 140 to 199, it is GDM. So now, what are the other tests which can be done? Though they are not screening, but do you like to do, sir? B.S. Jodha, sir? How many? We have Dr. Sapna with us now. Dr. Sapna, are you there?
Yes, ma'am.
Dr. Sapna, please tell us, do you do any other test to confirm your diagnosis? Or are you worried about your patient? Suppose patient was diabetes pre-gestational. Would you like to do some other test? Anyone, please, sir?
So the test which, if a patient who has a screen positive for that particular time, then it is
10 weeks positive,
dictum, then we
history
do.
of mother having diabetes. So would you like to do
it is a
something?
dictum to confirm it with it. This was the screening test. And if we have to confirm it, then we have to do the oral glucose tolerance test.
OGTT.
OGTT is to be done. And simultaneously, we send the sample for HbA1c to
yes.
assess the situation, what was previous 3 months. What is the status of that?
And
So
that is
these are, along with the other tests which can be done for these patients who are having high number than other tests and blood pressure management.
So, why do we do this HbA1c? What do we come to know?
Then if HbA1c is more than 6.5, it is definitely a patient who is a pre-gestational diabetic group. Then if it is lesser than that, then the risk of which can be explained to these patients that there can be possibility of uncontrolled diabetes at the time of embryogenesis. There can be risk which can be increased for this. So this can be used for a counseling part and then later follow up in sonography and to detect and to keep eye on that particular patient who is at risk.
Sir, just a simple question. I mean, I just wanted to share, if you do HbA1c and you find that the patient's A1c is 9%,
yeah.
So what do you suggest? Do you suggest her to get the pregnancy terminated?
No, we are not advising these, but at least we should be able to counsel these patients that you have gone to that particular pregnancy without taking your glucose level controlled. You are at risk of developing these types of cardiac anomalies, CNS and other quadril. So this can be the risk. So at least sometimes we may miss these things, but at least we should be able to say that these are the risk you are carrying because of your uncontrolled diabetes. So previous
so
to
that is verbally you all say, sir, you take a consent also regarding this. Suppose patient want to continue the pregnancy.
And we can write it on the patient's consultation paper that it has been counseled to patient and attendant.
To save yourself from
so
the
it is a document.
Yes.
That at least nowadays patients are that you have missed this diagnosis. Certain types of cardiac defects which cannot be picked up at 16, 18, like VSD and ASD, which require 20 weeks plus. Then these patients, or we have to switch over for the late 20 weeks around or these fetal echocardiography.
Ma'am, another thing, I wanted to say that if it's like up till 6.5% also, we have to say that there can still be a risk of 2% of chromosome, like congenital anomalies can be there. Even up to,
the moment the HbA1c is more than 5.6, say more than 6, then you have to be very clear counseling.
Yes, ma'am. So in the table, it was written and not increased risk. So I was just telling there is a 2% increased risk. And then up to like 8.5, the risk can be up to 20%. Instead of 5%, we have to counsel them about 20% risk is there, ma'am.
So that should be written, as Dr. Jodha sir has said, should be documented also that we have explained, because these days we are having so much medical implications on us, so just to save ourselves.
I had a case of caudal agenesis, ma'am. She was never diagnosed previous to abortion, and she, when she came to me for level 1, there was caudal agenesis, and her HbA1c was 6.4 only. So we see that we have to be slightly more, explain more rather than saying it nahi hoga, kuch ho sakta hai. So that is
proper counseling is very, very important.
Yes, ma'am. Yes, sir.
Detailed anomaly scan should be done. And consent, as rightly said, detailed consent is very important. Like right away, we can't advise them abortion on this basis only.
We cannot.
So, yeah.
But above 8.5, ma'am, we can give them the thing, and then it is their choice, na? And then the follow-up will be there.
Then we are not in a soup. Otherwise,
right. We have to give them choice.
Yes.
We have to proper counsel them and say these are the consequences. Yes. And what is your choice? That's important.
So, Dr. Sapna, what are the complications of DDM? How do you explain your patient that you are having, because patient they're so anxious and they're so pampered, the pregnant ladies are so pampered these days. So they will have a lot of questions. So kuch hoga ki nahi mere bacche ko, mujhe kuch hoga ki nahi, even the mother-in-law start asking. So so let us know from you. So what are the complications you explain to the mother and to her mother-in-law? So maternal and fetal complications, we would like to hear from you. Dr. Sapna?
Ma'am.
Yes, please.
The fetal complication in which?
Yeah.
Maternal complications.
Uncontrolled DDM, there can be macrosomia.
Yes.
Hypoglycemia after delivery, hypocalcemia, hypomagnesemia, and RDS also there can be.
That is fetal, na? Maternal. So many read out, na? For us also.
There may be after delivery tears.
Yeah.
Yes.
And long-term type 2 diabetes.
Yes.
Yes.
These are the complications, maternal, macrosomia. Most of the time you have to do cesarean.
Yeah.
And there is risk of hypertension also. The diabetic patients may develop hypertension. They may develop polyhydramnios. Preterm delivery is very common. Spontaneous, there is risk of spontaneous abortion, and long-term diabetes also can occur after 20 years.
So, yeah. So in the management itself, ma'am, we can start ecosprin because preeclampsia is very common in the cases of GDM. So that is one thing that I read, that in the antenatal management, because of the increased incidence of.
So, there is no harm. If you start before 16 weeks, it will do more benefit.
Yes.
You have to see that if you are starting at 24 weeks, then it has no benefit.
So, yeah, that is there.
It should be started early, you know.
Yeah,
I think,
that is why it's like the early screening is important, and the screening
so that you can start your ecosprin.
Yeah.
So these are the neonatal complications. Dr. Sapna, I've already said now, this neonatal hypoglycemia and everything.
Yeah.
So this how hyperinsulinemia affects the fetus. So this is a very beautiful slide. I got it from somewhere. So it causes organomegaly, especially the liver and the heart, and it also cause of decreased surfactant. The hyperinsulinemia causes decrease of the surfactant. So there is always, they are at risk of RDS, very common in the GDM patients. Then hyperinsulinemia also has growth, insulin-like growth factor, we all know. So the babies are macrosomic, and then there is risk of birth trauma to the mother as well as to the fetus. And again, there is, because of the hyperglycemia of the mother, is processed, the placenta goes to the fetus start producing insulin, and that causes at birth, most of the time we have to do fetal blood sugar measurement, the newborn blood sugar management, to rule out the neonatal hypoglycemia. This is very common. And then there is risk of RDS, so there is risk of intrapartum asphyxia. And there is one thing very important, there is a risk of increased erythropoietin. Can anybody explain why there is increased erythropoietin?
Like a stimulation of
Dr. I think Jodha sir, you can tell us why there is polycythemia.
Fetal liver by the increased glucose simultaneously, then there is stimulation of the kidneys also occur, and the fetal erythropoietin secretion increases, which is cause of polycythemia.
Yes. And this polycythemia causes
hyperviscosity
due to polycythemia.
Yeah,
and then there is risk of this thing, seizures and all in the
baby. That's there.
You must have seen many times.
Yeah, so maybe this hyperviscosity is a cause of preeclampsia, or like maybe that is interrelated, sir. I don't know. Maybe
it is a fetal polycythemia.
It is fetal polycythemia.
It is
But
yeah, I know it is.
But you know, fetal seizures we have seen so many times.
Yeah, exactly.
After seizure, even after normal delivery also.
Neurological deficits and this can occur. The ICH.
So very nice discussions we are having, and all the doubts are also being cleared.
Yeah, exactly.
So this is the case, Dr. Suburi, you were telling about the sacroiliagenesis. And there is two risks, caudal regression syndrome and the sacroiliagenesis. This is from our patient only.
Yeah. So the evaluation of the spine and the skeleton is very important in the borderline cases also, and even in unspecified cases, and preferably do a transvaginal scan to rule out each and every segment, because mine was having just the last thing was not there. So we sent the patient for MRI at 11 weeks, 4 days, we diagnosed it, and the patient got aborted at that time. So it was like this.
So this, there is another case. This is also very interesting. A 29-year-old lady, she weighs 70 kg. She is gravida 4. Para 1, and she has 2 abortions. Presented with single live fetus of 27 weeks. On her ANC evaluation, she was never examined by any gynecologist, not even to any medical officer also. And then she came to the OPD, and her we did a glucose tolerance test. The fasting and PP. No, actually, when the patient comes very late, now it is better to do DIPSI test. Sometimes you like to do fasting PP both to see, just to, I mean, just as a habit, you can say, because sometimes we like to do fasting PP both. We write by our old habit, and then we saw that the fasting was very high. It was 106, and PP was after 1 hour. I did it was like OGTT only, and 1 hour was 184, and 2 hour was 168. This was the same. So, Dr. Sapna, what will you do in this case?
I'm not
in case of GDM, na? Because after 2 hours, if you do a DIPSI test also, it would have been 168. 2 hour glucose level would have been 168. So now you can see that the 2 hour glucose level is 168. So she is a case of GDM. Would you like to treat this case or leave her?
No, we will treat this case. We'll follow up. We will.
You ask her anything. If her 2 hour blood glucose is 168, would you like to do take any history? Because he has come to you after, the 27th week.
Any previous history of GDM, or in maternal side there is history
Yes.
of.
Yeah, yes, because he's Gravida 4, so previous history of
2 abortions are there, na?
Bad of BOH case she's.
Yes, he has this thing, bad obstetrical history, and then you will also ask history of the GDM also, and have my family history also you'll ask.
Yeah.
And what are the things you like to investigate? You'd like to do NC care, na? So what else you'd like to do in the management? What are other tests you'd like to do? I have done only this OGTT, and now would you like to do some other test also? Patient has come to you for the ANC antenatal care.
OGTT and glucose.
That has been done. That has been done, and she is now GDM. So now she has come under you, have taken the history, and you found her that she is GDM and like to treat the patient. Would you like to do some investigations? Like you do in your general patient, you do something more in this.
Ma'am, she should be evaluated thoroughly. Renal function test should be done. HbA1c should be repeated. We should do thyroid profile also.
Yes.
And
because most of the time you see that the thyroid hypothyroidism is associated with diabetes. So
yeah, and blood sugar level, like fasting one, and then post breakfast 2 hours, then PP, then post dinner. So at least 4 to 5 times a day she should be evaluated. And
yeah.
So till stabilization, we have to evaluate, and the therapy, especially in this group of patients, we can try for 7 to 10 days. Medical nutritional therapy is in the range. If patient responds well, if she is stabilized and she has learned the counseling which we have given regarding the diet and exercise, so if it is well controlled, then it is good. Otherwise, it is better to start, because the things which are going to worsen in this third trimester, this hyperglycemia is going to worsen.
Yes.
So the dosage requirement for insulin, or if you are starting at least metformin for insulin sensitization, then it can be added to this group of patient.
But there is a controversy always. Patient has come to you early, sir, and you have found her to be a GDM case. So would you like to start with the metformin on insulin? Because whenever you say insulin, patient wants to run away. They don't take anything. So,
because these drugs are now, the metformin is a category B drug, and if you get this result, the patient can be counseled that the period of 7 to 10 days which we are taking with your diet and this much of exercise and this drug, if it is controlled, is better. Otherwise, we have to counsel that this worsening of hyperglycemia will affect your outcome. Then the patient accepts the things, and we can counsel. And the requirement of insulin in such patients who are very minimal, and doses of insulin will be able to control this much of along with the diet and exercise will be helpful for such patients.
Yeah, we can start with the nutrition therapy and the metformin. And the metformin, we can go up to 2 grams. Like we have to start with 500 grams and we can go up to repeat the blood sugar and the postprandial levels. And if this,
but it is said that it has been said that before 20 weeks, Government of India doesn't, advise to give.
Yeah, ma'am. Yeah, but it has changed now because many of the PCOS patients, many of the PCOS patients who are receiving metformin and they conceive, they continue metformin.
Yeah,
so
now physicians are accepting this.
Yes. So now the physicians, the previous block was there, okay, don't start before 20 weeks, but the counter argument has been that okay, we are giving in PCOD and we want the pregnancy to be continued with the low glycemic this thing. So a better glycemic control is achieved by metformin, but if the fasting blood sugar continues, like it is not controlled only on metformin, you can start with low dose of insulin. Similarly, with the insulin, you can add metformin if the patient is not easily controlled with the standard dose of insulin, because the hypoglycemia chances are more with the insulin if not correctly monitored as compared to metformin.
Very
But
right.
so
We have used in better patients and with good outcomes.
Can I add, madam?
Yes, ma'am. Dr. Kanchan, you wanted to say something? Ma'am.
I was saying very rightly, you said that because in PCOS patient, there is in many cases, there is insulin resistance also. So we do start and these patients do conceive when we add the metformin and we do continue with the metformin. And if the blood glucose level, they are even being controlled by this. If they are not being controlled, then we have to add
insulin.
That
Yes,
is a very right.
Thank you, ma'am.
Good. So we all agree that we can start before 20 weeks metformin.
Yes.
This
Yes,
has been
and
agreed
this
by
case
all
is
the-
so 27 weeks, so no.
So
this
no,
case
I'm not
is
talking
like,
about this case.
yeah.
Just
In fact,
came to my mind to share with you all.
Yeah.
So it has crossed all the limits of central government's cap of 24 weeks already. So we don't have any options
Exactly.
to go through.
Exactly. And the second thing about the investigation is like that, like we have to see all end organs like the kidney and the retina. So these are the things that come in the investigations that locally you have to see the kidney function test. You have to evaluate the retina if there is any kind of things which you feel that it's not
Madam,
really just simple diabetes, or there are other organs being involved. So things have to be more aggressive. The management of sugar has to be more aggressive, and then so it has to be added here.
Madam, can I add something?
Yes.
Madam? Yeah.
Yes, sir.
I do agree with all the panelists here, but the thing is that it is a duration of a diabetes that is much more important rather than going for an end organ damage. Because in an end organ damage, the duration of blood sugars which is deranged, if over a period of a longer time, then and then only it going to occur for the kidneys and for the retina, not on the earlier side.
Yeah,
So
especially not
it is
in
typically-
GDM, it is in over diabetics patients.
Yes.
Yeah.
So it is a over
But
diabetes
this,
where you should be putting
this
it
patient is
for that
visiting us as
particular
27 weeks now. We don't know whether it is old or new. So.
This is a GDM, so I thought it is not the mandatory to do all the tests for the particular things, because GDM
The
usually
first
not going
visit,
to affect the end organs.
We had the opportunity to at least exclude these things.
Yes.
Yeah, at least
We have to
exclude.
do it
because-
now. We should do it, I think.
Yeah, because and gynecologists are scared ones, like we want kar lo bhaiya, baad mein na kuch kahe ki nahi kya. So we are like drivers, like when we drive car, we are scared ki koi hame na thoke. The same way when we are in the clinic, we want to evaluate everything, because the cost of investigation is not too much, but the cost of the things that come later on as well is much more.
Frightening, you can say.
Very right.
Because
Better
the
to
court
know
will
all
ask you, were there any tests you should have done? Yes. Then why did you do? At least we have to write, sir.
Exactly.
We should write on with the pen, we should write on the paper. So
सुबह इस जमाने की है, हमारे जमाने में तो चल गया ये.
नहीं सर, यहाँ गुड़गांव में तो कुछ नहीं चलता. आप नहीं लिखेंगे, दूसरे हो कहेंगे इसने लिखा क्यों नहीं. So you have to be on top of your seat. And
डॉक्टर सुप्रिया नहीं, यहाँ भी आप नहीं लिखो ना, दूसरे जगह चले जाते हैं.
Yeah, you have to
कोई टेस्ट ही नहीं लिखा.
So the thyroid is important, urine test is important, and RFT and fundoscopy are important in this. So
fundoscopy करने में हाँ वो कर लेना चाहिए, but I know कि GDM में कुछ नहीं निकलेगा because long
but now patient coming for the first time, how do we know that it is GDM? Like 27 weeks?
No.
So
27 weeks में direct आई हम लोग के पास में 2 abortion लेके.
We have to follow these postpartum also then, and then we will be able to see it and the level of HbA1c.
Good Doppler study should be done.
At 28 weeks. At 28 weeks. No?
Yeah. Yeah.
So how do we, I mean, call our patient? Like normal ANC, what we do, we call every month at till.
No, we call them more frequently.
She has come at 28 weeks, so I think every 15 days we should call her.
Yes.
Yes.
Actually, almost he has come at 28 weeks. So every bi-weekly, yes, but twice. Though after 2 weeks we should call it.
Yeah. And yeah, in this way, I definitely tell whenever the patient is like that to watch the fetal movement count also. Whether you are coming or not coming, please see if the kicks are not that forceful. Even if the baby is moving, but you are not feeling the same kick, then also respond, because like I do a lot of color Dopplers, but I understand that mothers, the feeling perception, mother's perception is the first thing that has to be actually.
About the movements.
Excuse me, Suman madam, we have to hurry up 15 minutes, okay?
Okay.
So there is one, now we are moving, I'm going to give this to Dr. Kanchan. I will be sharing the slides, we'll answer questions. Just we are moving to another
Stop sharing. Dr. Suman, please stop sharing. I'll share and move according to me.
Case 3, okay? So I have stopped. It was really very interesting. So many things we came to know.
Yeah, very interesting panel and lot of interaction.
Yes.
Thank you. We still have 2-3 cases left. To learn, we sacrifice our evening clinic.
Oh.
We prepare like a table viva now also.
My slides are visible.
Yes, it is.
Yes.
Yeah, I'm audible. First of all, my sincere regards and thanks to all, and I welcome one and all for giving your precious time in this evening. Busy, as Subhi was saying, that we have our clinic and we learn to sacrifice our clinic. I thank the organizers. I thank Dr. Pratibha, Dr. Suman, Dr. Manoj, and Dr. Ashish Kale, and all the wonderful panelists whom I was hearing since long. Dr. Joda, Dr. Suboi, Dr. Sapna, all very active. Dr. Manoj, very actively answering. Thank you. And I think in short, now we have to proceed and try to finish in a very short time. Lot much has been discussed. There's a third case. In this case, Mrs. X. She is 33 years old lady diagnosed with diabetes in the present pregnancy. And the routine glucose challenge test performed at 28 weeks was elevated. That was 208 milligram per dl, so high. Her HbA1c was elevated 7.6% and fundus examination revealed no changes. So the question to Dr. Joda, sir, what is the ideal management of the case? What is MNT, role of exercise? There are so many questions we can share and discuss. What is the target glucose level? What is SMBG and role of oral hypoglycemic agents, types, doses? We will be discussing all this. Role of insulin and when to start and what is the type and dose of the insulin. So coming on the first question, sir.
So we have almost discussed these things in topics or most of the things.
Yeah.
So the patient is seemingly with the high HbA1c and the blood sugar, which is over 200 milligrams, seems to be a diabetic one, which has not been picked up earlier, because 7.6 suggests that it is much earlier. And these patients, along with our drug, which we are to start for such patient, is insulin, along with diet and exercise. And we can have also the group of these insulin sensitizers, which can be added, which can have a better control of blood sugar level with little bit of reduced level, use of insulin because of risk of hypoglycemia in such patients, which may be, and it is better to have. And these patients are guided that they should have self-monitoring of blood glucose, which is to be taught to these patients while sitting on your consultation chambers, or even you can admit for these patients for 2 or 3 days to at least stabilize initially, so they can learn to seeing their samples. And at least for initial 3-4 days, we have to have at least 4 to 5 tests per day, that fasting, post breakfast 2 hours, and post lunch and post dinner. So patient will learn that these are the things, and this diet has made me able to control my blood sugar, which is if she has picked up these things, then it is better. Then we can discharge her and call her at least weekly, and after stabilization, the patient may do these things on a twice weekly or weekly basis. She will learn these things to be controlled.
And do you all give GDM safe? Do you all give GDM safe for 2 weeks? Do you all give containing we advise to the patients in the MNT. I write GDM safe, you know, it consists of myoinositol and D-chiro-inositol. Do you all prescribe?
Yeah.
With vitamin D3.
Actually, we are all giving that. So, as very rightly said, sir, that 4 samples should be taken, ideally fasting 2 hours post breakfast, 2 hours post lunch, and 2 hours post dinner. And we are giving these are the target levels.
Yes.
And we are saying them to make this type of the table. We are giving and tell them to maintain this type of table and enter your blood glucose level. Especially the 3 a.m. Night blood glucose level is to be monitored. In
sometimes
these
these patients may have complaints in the morning that in night time they had problems with the perspirations and headache, and they suddenly got up, and especially the patient is admitted, the nursing staff has given 2 spoons of sugars in these patients. के patient को बहुत ज़्यादा hypoglycemia हो रहा था, मैंने फटाफट दे दिया. So these are the effects which we observe in such group of patients who are on insulin.
So, and many times we have seen fetal death also at 3 a.m. 3 a.m. due to the maternal hypoglycemia, there is fetal hypoglycemia.
On the Somagi and on phenomena. So, Dr. Suboi, I have seen that your fundas are very clear and you're very clearly speaking all the matters. So let us, and you have maintained yourself also thin and lean, and just, I think your nutritional funda is very clear. So let us hear from you about the nutritional therapy in these diabetic patients.
Okay, ma'am. Basically, thank you once again for all the compliments. Basically, what we do in the medical nutritional therapy, we have to understand about the carbohydrate, proteins, and fats and their actions. So in the carbohydrates, well, the 3 major meals have to be divided into 3 lighter meals and 3 snacks. So instead of giving bulk at 3 different, we have to spread it into 6 things, like 3 meals which are lighter. The carbohydrate has to be like 40 to 60% in the form of preferably a complex carbohydrates, which have got low glycemic index as compared to simple carbohydrates. So that is there. Then protein is around 15 to 20% or 20 to 40%. That is there. And the fat is to be less than like 10%. The fat again has to be decreased. Like you have to see the quality of fat which you are installing, and then how the 6 meals have to be given. That is again very important. And then there is a typical plate which they make for the diabetic diet, in which they increase the salads and the multicolored vegetables and decrease the carbohydrate part and increase like the protein part. So that is how they see. And then the diet again has to be seen. There is a calculation which they give upon a BMI into physical activity. That calculation can be done to be very precise in your this thing. Otherwise, generally speaking, if you're a sedentary worker, mild or a heavy worker, the calorie intake has to be accordingly calculated. And then you add 350 grams more for the pregnancy requirements. And if the patient is underweight at the beginning, then you increase 500 grams more. But if the patient is overweight, you have to minus 500 in the total calculations or the calorie requirement. So that can be the general thing. Like if the sedentary worker is like 2250 kilocalories, you have to distribute it over a day. And if it is like a moderate worker, then 2580 calories. And if it's a heavy worker, then it's 3,200 calories have to be given, and my plus and minus 500 according to the level of the, if it's underweight or overweight. That is my take on it.
Very rightly explained. You can have these type of the tables in your OPD just to convince your patient. Yes. They will be convinced better. Otherwise, you will make them understand, they'll not convince.
So we preferably have a dietitian explaining it to the patient most of the time. So it's like a multidisciplinary. So this kind of sugar, we have a physician also, so that we form a team rather than we ourselves getting into all these many things. So that is how we follow here.
That is always better, and we always prefer a nutritionist.
Yes.
That is a criteria nowadays.
Yes.
Dr. Ashish, will you tell something about few words regarding the exercise in these patients? How and what type of exercise you will prefer and advise these patients?
Madam, when we're talking about the exercise, I personally believe it is an individualist choice. So whenever we are talking about something, you should not enforce upon you have to do something like this or some exercise. If she is comfortable enough to do the routine walk, she can do the walk routinely, or whatever she is comfortable with, it has to be done. Usually advised every day she has to maintain her lifestyle, whatever exercise she is doing. Upper limb exercise is usually very much easier to do rather than we can advise, rather than asking her to do some complex exercise or something like that. I think in my set of practice, we advise to them a regular walking. That's all.
Oh.
Because if you go on quoting them the incidences that particular patient that started doing some exercise and they got the result, and that particular patient was lethargic and was not having, go on quoting and counseling, and they will start doing the exercise that I have seen in my practice.
Yeah. So I read about exercise, ma'am. And I also realized that, okay, generally we talk about exercise, thoda sa bhag lo, daud lo, but I thought it is a question I have to read. So I realized that we have to tell them about the aerobic exercises, and we have to tell them about strength training. And that's called resistant training. And both these exercises, they have given beautiful chart for diabetes, that how the exercises should move the major muscles, as well as about the strength training, which will increase the overall strength and ultimately increase the insulin utilization in these patients. So sorry, glucose utilization in the cells. So that is important. And again, yoga is again inspired because it's like mind, body, and this thing. So this is a beautifully explained for ma'am. Exercises in diabetes are done very well. So
yeah,
I was happy.
You have very clear fundas about this exercise and diet. I appreciate it. And even I love the exercise and this nutritional therapy.
Yeah.
And now, although this has been discussed, but in a short, we can ask about the oral anti-diabetic drugs. So, sir, Dr. Jodha, sir.
Yeah, because biguanides like metformin for insulin sensitization, and another group of drug which is like glibenclamide, gluburide, has been used in group of patients, but it is a category C drug, and we have to keep in mind that they are at risk of developing certain type of hypoglycemic episodes in such patients. So the patients who are not able to take or afraid of taking these insulin injections, or we are seeing that the blood glucose level is not controlled because of skipping these injections. So we can put these patients on such oral hypoglycemic agents, keeping in mind that this may be much more easier for patient, and at least we will get that blood sugar will be controlled. If it is not controlled, then we have to counsel that this drug has been taken, but you are at risk of having maternal and fetal complications, without which we have to add these things. So this group of patients, we can utilize these group of.
But are we giving glyburide? We are not normally giving glyburide.
We are not normally giving.
Not in practice of using
Yes.
it, because
Maybe we are scared. I don't know the name itself.
Even I am not using.
Though it says it's a category B drug and it's not teratogenic, but still it's not.
no, it is a
that commonly
category
used.
C drug. It's glyburide is a category C. Metformin is B.
Yeah, metformin.
Metformin we have already discussed a lot.
Yeah.
So omitting it, coming on the insulin therapy in short. So Dr. Manoj, will you discuss about insulin therapy? Which type of insulin, Dr. Ashish? Will you discuss? Dr. Manoj or Dr.
Long-acting insulin bases can be given, and the short-acting insulin mimics the physiological insulin release. So regular insulin can be given 10 to 40 minutes prior to the meals, and dose of insulin varies like 0.6 to 1 unit per kg per day in divided doses, and it all depends upon the trimester. So like in the morning, 2/3 dose can be given, and in the night, 1/3, and then the long-acting 2/3, and then you can divide 1/3 and half and half. So morning dose is 2/3 NPH plus 1/3 short-acting, and the pre-dinner dose will be half NPH plus half dose of short-acting.
Rightly said. Actually, there are short-acting, long-acting, and the combined. Combined preparations are also available in the market. The short-acting are Lispro, Aspart, which we are normally using. The onset of action is less than 15 minutes in these short-acting, and peak is 30 to 90 minutes, and duration of action is 3 to 4 hours in these cases. And long-acting is NPH, Detimer, and Glargine. Usually, these were avoided initially, long-acting, which we are giving in late night, where there is early morning rise of blood sugar.
Yeah, there's a chance of hypoglycemia in the morning.
In those cases, we were giving it, but in the pregnancy, better to avoid. In case needed, we do give it. Its onset of action is 1 to 4 hours, and peak is 6 to hours, and duration of action is 10 to 16 or 24 hours at least. So high. We are usually using combined preparations, that is which are biphasic. Amongst them, NPH is most commonly being used, 70-30 we all use in our practice. These have a dual mode of action. That I have already discussed. Total daily dose of insulin, if we see that insulin in the morning 2/3 and night 1/3. 2/3 is long-acting and 1/3 short-acting combination we are giving. In the night, half long-acting and half short-acting. So other investigations which are needed, we have already discussed. This is a big table. Anyone will explain how we will proceed? Should we discuss, or we are going long enough?
We are already late, ma'am. We have discussed most of these things. And
so we have discussed. What about Somagi and Dawn phenomena? So
basically, Somagi's phenomena is post-hypoglycemic hyperglycemia. There's rebound hyperglycemia following an episode of hypoglycemia due to release of, like we know, counter-regulatory hormones. So correction of this morning hypoglycemia depends upon the reducing the dose of insulin in the night. So we should be very careful when we give the dose, what dose we are giving in the night. And in dawn phenomena, there is a fasting hyperglycemia without the episode of hypoglycemia. So management is by then again increasing the dose of night insulin.
Very difficult, na?
How to differentiate the 3 AM blood glucose? There is a
Then in the night,
hypoglycemia in that case.
midnight, he can do the blood sugar level.
Yeah.
That can be made
Early morning, yeah. 3 o'clock, dawn.
So case 4 we are omitting. And
just the postpartum thing now. Postpartum thing. Last case.
All are saying that we got late.
So interesting.
Postpartum,
this thing.
You can conclude the things. Yeah.
Ma'am, you can conclude. You can tell us.
Yeah, you can conclude that.
So contraception coming on in short, what are the contraceptions which are advised? Suboi, in short, you can discuss just.
Ma'am, in the well-controlled patient with blood sugar well-controlled and with no end organ damage or no complications, the patient can be offered any contraception. And they are like 1, 2, 3, 4, like usually offered, and the second there are some. So all the if uncontrolled, all can be given. Preferably intrauterine devices are can be prescribed in all this thing, and combined pills are not actually given in the 3rd and 4th, like the patients which are having end organ damage or complications. So we differ from that. So they fall in 3rd and 4th category in the patients with complications. Otherwise, everything has got 2 mark. I have got the screenshot for that.
The IUCDs can be given, but then we have to be careful about the
infection. We know that actinomycosis we have to be careful of, but it is prescribed that we are more scared and we land up having more unplanned pregnancy in diabetics because we are actually reluctant to give them hormonal, and they have seen that the studies have showed that they are not causing that much of imbalance as we were thinking them to be. So we have to be more prompt in giving them and providing them better contraceptive advice after their delivery, so that they are less complicated things for the female. So,
Madam, what I wish to add here, you have to just advise her for LARC, so long acting any hormonal contraception. So that is a better thing for them.
Well taken, Dr. Ashish, but the thing is that not everybody is ready for IUCD. So the combined oral pills now which are available in the market can be safely advised. Yeah.
Low dose combined oral contraceptive.
Yes, ma'am, they are prescribed.
Can be advised in this patient. It doesn't have any complication.
Depot preparation can also be given in these
cases. Yes, all the prescriptions like combined depot, progesterone only pills, all can be given. They are not given in the patients who are having diabetes with complications. They fall in the category of 3 and 4. So I will forward that slide in the group also, so that we can have this thing.
Yes, thank you.
So ending our discussion, and this was a nice interactive session, just interacting with the brilliant panel, intelligent panel, had a brilliant discussion.
Thank you very much, ma'am.
Dr. Joda, Dr. Suboi, very nice views and interaction, and Dr. Manoj and Ashish, Dr. Sapna, all have
How you pronounce Subhi or Suboi?
It means it's Subuhi. It's Subuhi. It's Subuhi. It means a good morning.
Okay. It is a good evening now. Thank you.
Thank you very
much.
Now we are going to say good night to all of you.
Thank you so much
Best wishes
for making us learn so many things.
We already
You all have made it so interactive, and I mean,
we have already sent your nominations already, and we will be sending your.
Thank you, sir. Thank you, ma'am. And
we all give the voted hands.
Thank you so much. Now,
for our nominations, you have sent for our voting. Vote for myself for the study of breast committee, Dr. Suman Sinha for the clinical academic exchange committee for
sure. All the best.
Thank you.
Thank you,
Now
Dr.
I will request Dr. Priyankur Roy to vote of the hand.
Is there?
Where is Dr. Priyankur riding?
That's why.
Okay,
I
driving.
request the support to kindly put his CV, Dr. Priyankur Roy CV.
It's okay, ma'am. Doesn't matter. It's okay.
Achha.
He's going to treat us after he wins.
Yeah. So Dr.
Dr. Priyankur is known by everyone. So he is the National Coordinator of Perinatology Committee FOXI. He is on Coordinator Infertility and Endocrinology Committee FOXI, and he is mainly National Coordinator for Public Awareness Committee of FOXI, and he's standing for the post of Chairperson Public Awareness Committee FOXI. So all the best to him. Kindly propose the vote of thanks.
Sure.
Thank you so much, Supriya ma'am, for those lovely words. And I wish you all heartfelt thanks for being with us for today's mixed bag program of the Knowledge Byte series. So it's been a wonderful session over the last 3 hours, I must say, and a beautiful discussion that has happened. So I would first of all like to thank our chief guest, Dr. Leela Vyas ma'am, the guest of honor, Dr. Richa Sharma ma'am, for gracing the occasion, and of course our convener, Dr. Supriya Jaiswal, for coordinating the whole entire session. My special words of gratitude to the speakers of today's evening, Dr. Ragini Agarwal ma'am, Dr. Anju Soni ma'am, and Dr. Pratibha Singh ma'am, and of course to our learned chairpersons, Dr. Preetam, Dr. Prakash Jain, Dr. Anjali, Dr. Sudesh Agarwal, Dr. Kiran Arora, Dr. Nishi Gupta, Dr. Kiran Chandana, Dr. Poonam Lumba, and Dr. Pradeep for being with us and sharing the session so wonderfully. I would also like to thank the moderators of today's evening panel discussion, Dr. Suman Sinha and Dr. Kanchan Sharma, and of course our expert battery of panelists. Experts, I must say, Dr. Vidhu Modgil, Dr. Jodha sir, Dr. Suboi Rizvi ma'am, Dr. Manoj Chellani, Dr. Ashish Kale, Dr. Chanchal Gupta, and Dr. Sapna Jindal. Thank you so much once again for joining us. I would also like to thank our academic partners, Shield, who has provided this platform to us, and overall all the attendees who have attended with us, because our program is never successful when there's no delegates or attendees. Thank you so much once again. Thank you for being there with us. And I would like to thank and wish all the contestants for the election all the very best for your election. Thank you so much once again.
Thank you. All the best for everyone.
Thank you so much.
Thank you.
Thank you, Dr. Subodhi,
Thank you, Dr.
for continuously giving your inputs.
Oh, thank you so much.
Wonderful, wonderful.
Wonderfully,
All
you
the
explained
programs.
everything. You kept on talking on all the subjects, all the topics. Very
Glad,
nice,
I mean,
very well discussed.
And
Thank you so
you
much.
put up
Very, very
send me the
active.
slides so I can add in mine, you know.
Yeah.
Thank you so much.
So, bye-bye, everyone. We've come
Bye,
to the end of
everyone.
this
Thank you.
Bye,
meeting.
Dr. Pratibha,
Pratibha,
Dr. Kanchan,
Bye-bye.
Supriya, and
very
Dr.
well conducted and moderated whole of the session in a very
Yeah.
sweet voice.
Thanks.
And
I'm
as we always appreciate your sweet voice.
Yeah.
Thank you so much.
Thank you and all the best to
Bye-bye.
everyone. Good night.
Thank you.